Okay. Yesterday we have started with this epidemiology and the biostatics. We have skipped that part of the observation studies. I told you I will make separate slides of it and we'll discuss this today. Okay. And yesterday we have discussed the clinical trials, the phase 1, phase 2, phase 3, and phase 4. I've told you the randomization, the controlling, and the double blinding. It can reduce all the biases in a clinical trial. Okay. If you want to increase the study quality, you need to do 2, 3 things. Then 4 phases of the trial we have discussed. In the phase 1, only the healthy individuals will be taken. In phase 2, moderate number of patients will be taken, and these will be the diseased patient. Why you do the phase 2? In order to check whether a drug is working or not. Okay. Then we have discussed the phase 3, in which 2 groups have been selected. One who receives the treatment and second who do not receive the treatment. Okay. And in this phase 3, we determine whether drug has a superior thing or not, whether drug that we have developed is kind of a more superior than the previous treatments or not, right? And then finally the phase 4, which is a post-market surveilling. Okay, and in this we have discussed that. Just let me turn off the mic. In the phase 4, we have discussed that it is a post-marketing surveillance. Okay, and it is a surveillance study, and in this study you need to determine what are the other long-term side effects of a certain drug, right? Then we have discussed about the diagnostic tests. We have discussed the sensitivity. We have discussed the specificity. The sensitivity is with how much proportion of all the individuals that are having the disease you can easily detect them. Okay, and this test is actually good in ruling out of a disease. Okay, so if a test is have 100% sensitivity, then you can easily rule out those individuals which do not have the disease. Okay, and we have discussed that a specific test or if a test has a 100% specificity, then it could be used in ruling in the disease. You cannot rule out a disease with the specific test. You can only rule in the disease because this test has a very high false negative rate. Okay, and the sensitive test, it has a very high false positive rate. Okay, so always a screening test is always a high sensitivity test. Okay, then we have discussed the positive predicted value and the negative predicted value. We have discussed how this value changes with the incidence or the prevalence of the disease, right? We have discussed the cutoff value of a certain test, and we have discussed how changing the cutoff value can change the sensitivity, specificity, the positive predicted value and the negative predicted value of the test. We have discussed the likelihood ratio, which is a certain chances you have given to a test, that this test is kind of a certain confidence you have in your test after encountering a patient, right? So you will give them a likelihood ratio, right? Then that these are the chances that this test is a highly sensitive test or a highly specific test, right? Then we have also discussed the quantifying risk, all the odd ratios, the relative risk we have discussed. Okay, then we have discussed the relative risk reduction, in which I have told you about the absolute risk reduction, and then the comparison between the absolute risk reduction and the placebo. We have discussed the attributable risk, which is an absolute increase in the risk, right? The risk in the exposed group minus the risk in the exposed group we have discussed. Then we have discussed the absolute risk reduction, which is a true difference between the non-exposed group and the exposed group. We have discussed a number need to treat, number need to harm. We have discussed the hazards ratio, right? And today we will discuss the type of study designs. Okay, we will discuss that observation studies. And the first study is our cross-sectional study. You need to know that 2 types of studies exist. One are the observation studies, and second are the experimental studies. Okay, the observation studies, it includes a cross-section study, the case control study, the cohort study, and the twin coordinates study. Okay, in case of experimental study, we have the crossover study and we have the clinical trials. Okay, so today we will discuss the observation studies. First is the cross-section study. In the cross-section study, we are taking the individuals at a point of time. It's like taking a snapshot of a time, right? We are taking all the individuals at a point of time. For example, let's say you want to know that how much individuals in the United States are smokers. Okay, So you will take all the individuals with the smoking status and you will note it down. And you can easily tell, for example, like 25% of the New Yorkers or the 25% of US individuals are smokers. Okay. So basically what you are doing, you are a kind of knowing the prevalence of a certain disease or a prevalence of a risk factor. Very important to know. With the help of a cross-section study, you can easily determine the prevalence of a risk factor or a prevalence of a certain disease in a given population. Sometimes you can even get a two groups, for example, let's say smokers and non-smokers, and you want to know how much is the prevalence of a lung cancer in the smokers and in the non-smokers. So you will take the smoker group, you will take the non-smoker group, you will ask them or you will check if they have the lung cancer or not. Then you will analyze the data and you can easily tell what is the prevalence of lung cancer in the smokers and what is the prevalence of lung cancer in the non-smokers. Okay, so it can easily show you how our risk factor is associated with the disease. It is telling me that how much the smoking is associated with the lung cancer, but I cannot tell whether the smoking is responsible for the lung cancer or not, because I have not taken any history of the patient. I have not following them for a period of time. So I cannot tell what causes the cancer in real life. It could be a radiation, it could be a food, it could be anything, right? So I cannot tell whether the smoking is a cause of lung cancer or not. I can only tell that smoking is associated with with the with this lung cancer. I can tell that all the individuals who are having the lung cancer, they have a very high incidence or prevalence of the smoking, but I cannot tell whether the smoking is causing the lung cancer or not. Okay, so it can tell you that a risk factor is associated with the disease. When the disease increased, the risk factor is increased. When the risk factor is increased, the disease increased. But it do not tells us how the disease casualty is established. Okay, very much important to know. Okay, so most important thing to understand is the patients are neither being followed for a month. Okay, and we neither and nor we go back in time and look for the record. So there is no time given in case of a cross-section studies. Okay, and it just tell you what is the prevalence of a certain risk factor or what is the prevalence of a certain disease in the given population, right? It will tell you just this part. Okay, whenever there is no time period given, no following time, no going back in time is given, that means it must be the cross-section studies. And whenever a time period is given that the patients are being followed for like years or something like that, then it cannot be a cross-section study. Okay, and sometimes what happens, the cross-section studies take time to for the completion. For example, you're taking all the individuals with the history of smoking, and now you're checking if they have the cancer or not, right? So it will take time for the study to complete. It will take for like 7 days or 8 days to know all the statuses of the patients, right? So do not confuse this with the case control or the cohort. A small time period could be given in case of a cross-section study, but only because there are lots of sample to be analyzed, and that's why analyzing these samples can take time, like 4 days, 5 days, or 6 days. Okay, but you are not following any specific individual or a specific group. Okay, you are just noting their history, you're just knowing their status, and then you're analyzing it. So if a small period of time is given like 7 days or 8 days, then also you will take the cross-section study, not the case control or the cohort study. Generally, the case control or the cohort study go back in like months or years, not the days. Okay, very much important to know. So any doubt in the cross-section study?
No.
Okay. Now we will discuss the case control study and the cohort study. Okay. And okay. So first is your cohort study. What is a cohort? So cohort is a group of all the individuals which have a common characteristics, like the smoking or same demographics, right? So all the individuals which have a common characteristic or the characteristic of your interest, for like you want to discuss all the patients who are having a smoking history. So these are the cohort, or the individuals with the age like 18 to 70. This is a cohort. So all the individuals which have a common characteristic of your interest is a cohort. So what is the aim of a cohort study? Okay. The aim of the cohort study is to determine the incidence rate, which is the first thing. Okay. First thing is to determine the incidence rate of a certain disease. Okay. Second thing, you want to determine whether a risk factor is causing the outcome or not. Okay. Whether the risk factor or the exposure of the risk factor is causing the disease or the outcome or not. Okay. And you can also check, did the exposure change the likelihood of the disease? Did the exposure I'm giving to the patient, it will change anyway the likelihood of having a disease or not? Okay. You can determine all these things with the help of a cohort study. See, in a cohort study, first you will select a group of individuals which are having a common characteristics, and these are the cohorts, right? And then you will divide them on the basis of the exposing status, whether they are exposed to the risk factors or whether they are not exposed to the risk factors. Okay. If they're exposed to the if they're exposed to a certain risk factor, then they can develop a disease 1, for example, the disease 2, or they might not develop any disease. Similarly, in case of a non-exposed individuals, they can develop the similar disease 1, disease 2, or sometimes no disease, right? Let's say an example of smoking. Okay, you have selected a cohort which have a in which some individuals have the smoking status and some individuals they do not have the smoking status, and now you want to determine whether the smoking can increase the risk of a lung cancer or not. But you guys also know that smoking can also cause certain type of cancer like esophageal cancer, like the gastric adenocarcinoma, less the and like the like the renal cell carcinoma, right? So a certain risk factor can actually causes 1, 2, 3, or many diseases. For like the disease 1, let it be a lung cancer. The disease 2, let it be a esophageal cancer, right? And similarly, those who are not exposed to risk factor, they can develop the similar diseases like the lung cancer and like the esophageal cancer. And let's say you now want to choose the disease of interest as a lung cancer, which is this disease 1, and then you will comparing. Okay, then you will comparing the prevalence or the incidence, or kind of you can say the frequency of the disease or the lung cancer in the exposed group and in the non-exposed group. Okay, so what's going to happen, the researchers will gather a group of study participants who have a common characteristics or the cohorts. Okay, then the participants are then and are then classified into the groups according to their exposure status. Okay, whether they have the exposure status or whether they do not have this exposure status. And finally, the incidence of the outcome of interest. Okay, well, and there could be many outcomes of a certain exposure, right? But you will choose the exposure of interest. You will choose the outcome of the interest. So you will check whether the interest, sorry, whether the incidence of the outcome of interest is compared between the two outgroups. Okay, so that you're gonna do. You will first select the patients on the basis of the exposure status. Then the disease of interest will be selected, and then you will compare the incidence of the outcome of interest in the two groups. Okay. Any doubts so far on this cohort study?
No.
Okay. So then there are two type of studies exist in the cohort study. One is the prospective cohort study, and second is the retrospective cohort study. Okay. In case of a prospective cohort study, you always go forward in the time. Okay. First, you will select the individuals on the basis of the exposure status, as we have discussed. Okay. Then you will divide them into two groups. One is the exposed group, second is the non-exposed group. Then these groups are followed over a period of time for like 6 years, 7 years, or 10 years, anytime you want, right? And then you will check how much of the exposed group patient develop the outcome, how much of the non-exposed patient develop the outcome, and then you will compare the results between two. Okay, let's say for an example, you want to do a study and you want to know whether the smoking causes a lung cancer or not. Okay, so you will select the individuals on the basis of the smoking status, all the individuals who have the smoking of greater than 1 pack of cigarette per day, which is a risk factor. And then you will follow them for like next 5 years to check whether they develop the outcome or not. Okay, and then the proportion of the of the outcome between the smokers and the non-smokers could be compared. Right, so a study that compares a proportion of individuals who currently smoke greater than 1 pack of cigarettes a day who develop the lung cancer in the next 5 years of the and to the proportion of the non-smokers who develop the lung cancer in the same period. So what you're going to do, you will compare the incidence of the lung cancer in the exposed group as well as in the non-exposed group. Okay. The second type of study in the cohort is the retrospective cohort study, in which you always want to go back in time. Okay. First, you will select a protocol of the study. Okay. Then the participants will be categorized on the basis of the exposure status. Okay. Whether they are having the exposure or not. For example, you could look back in the medical records of the patient. Let's say you're in the 2020 and you want to do a study and you want to assess the the association between the this smoking or the lung cancer. So what's going to happen, you will go back in the time in the 2008 or 2010 and you will look in the medical record of all the patients that you have selected. Okay, you have selected certain cohort, and in on these cohorts you will go forward, you will go backward in the medical records of these patients, let's say in 2010, and on the basis of this 2010 medical records you will check whether they have the exposure status or not. Okay, so it could be done by looking at the past medical records, right? And then these medical records are followed to the present time. Okay, in the 2020 you will check the medical records again of these patients, and then you will know whether they have the lung cancer or not. Okay, so for the exposure status you will go back in the time, you will check whether they have the smoking history or not, and then for the outcome status you will look at the present records of the patients and you will decide whether they develop the lung cancer or not. So this is the retrospective cohort studies. Okay. And finally, the two groups are then compared to see if the outcome is developed equally in both the groups, which means if there is no association between the risk factor or the outcome, or there is an association with the risk factor and the outcome. Okay. So that's how you're going to determine this. For example, a study that compares a proportion of all the individuals with a smoking history of greater than one pack of a cigarette per day 5 years ago. You will go back in time 5 years ago, which means 2015, and you will check for the smoking status. Then you will check after 5 years later, which is the present time, whether they developed the lung cancer or not. Okay. And you also want to know that the prospective studies are always more powerful studies than the retrospective studies. Why? Because you're relying on the medical records or the or some kind of a data of the patient. Okay, and sometimes what happened, the data might be that the data might not be recorded. Okay, and some data might be missing from the record. So ultimately what can happen, it will affect your study because you're just not looking at the every record, right? You are missing some record of the patients. Okay, and in case of a prospective studies, you're relying on your on your own data rather than any other medical record or something like that. Okay, so prospective studies are always more powerful studies than the retrospective studies. Okay, this is not data, it is data. Okay, because in case of a retrospective studies, you're relying on the data which is recorded at some point of time, and some data might be missing or some data might be might not be recorded in the patient, and that could affect your study again completely, right? So the prospective studies are more powerful than the retrospective studies. Now, what are the advantages of a cohort study? Okay, it can easily determine the incidence of a disease because you are given a certain exposure, and after the exposure you want to know how many patients develop the disease of interest. So how many are developing the disease of interest? This is your incidence, right? So you can easily determine the incidence with the help of the cohort studies. Okay. And and you can easily determine how a risk factor plays a role in development of a certain disease. Okay. Whether the risk factor is playing a role or not. Okay. And you can also determine how one exposure can lead to multiple outcomes. Okay, how one exposure can lead to multiple outcome versus in case of a case control study, you are checking how a disease can happen by multiple by multiple risk factors. See, in case of a cohort studies, you are looking how a single exposure can cause multiple outcomes, but in case of a case control study, you are looking at how one outcome can be caused by multiple exposures. Okay. For like say an example of the esophageal carcinoma. It can be caused by the hot drinks. It can be caused by the caustic soda. It can be caused by the Barrett's esophagus. It can be caused by the smoking. It can be caused by the alcohol. So once you determine which patient is having the history of esophageal cancer, or which patient is not having the history of esophageal cancer, you will go back in the time and you will look for the exposure status, whether they consumed alcohol, whether they consumed the smoking, whether they have the history of this GERD or not. Okay, so you can determine how one outcome can be caused by multiple risk factors. But in case of a cohort study, you're determining how one risk factor can cause multiple diseases. Okay, very much important though. And in case of a cohort study, you can easily determine the relative risk. So one thing is incidence. Second is a relative risk. Third is how exposure plays a role in developing of a disease. Okay, how one exposure can cause the multiple diseases. This is the fourth thing. So four advantages for the cohort study. What are the disadvantages of a cohort study? One thing, it is highly time consuming study. Okay, it has a very high cost. Okay, you always require a large study group. Okay, and one more thing, the attrition bias is present in this study, which means once you follow the patients over a period of time, then sometimes what happens, some patients might lost the follow up. So as a result, you have to exclude these patients from the study, and as a result, your sample size will be decreased, or the attrition of the sample size occurs, and that is called the attrition bias. Okay, so one of the disadvantages of a cohort study is the attrition bias. Okay, this is very much important to know. So any doubt in the cohort study?
No.
Okay, then comes the case control study. Okay, and again, in case of a case control study, you want to analyze, you want to know if a certain exposure, which is a risk factor, is associated with the outcome or not. Okay, the exposure is a risk factor and outcome is certain type of disease or a certain effect. Okay, so you want to determine whether the exposure is associated with the outcome or not. Okay, in case of a case control study, what you're going to do, you will select the individuals on the basis of that of the outcome. Okay, whether the individuals have the outcome, and those individuals which have the outcome or the disease, they are known as the cases. So disease group is known as the cases, and those individuals which do not have the outcome or the disease, they are known as the controls. Okay, so we have two groups. One is the case group and second is the control group, right? And on the basis of these groups, you will go back in the time. Okay, you will look for the medical records of these patients. For example, and the medical records, the employment records, the interviews or the surveys could be conducted, okay, to determine the exposure status of these patients, like 5 years back or 10 years back. Okay, so you want to know whether this individual who have the outcome, it has the exposure 1 or the exposure 2 or no exposure. Similarly, those individuals who do not have the disease or the control individuals, whether they have the exposure type 1 or the exposure type 2 or no exposure at all. And then you select one exposure. For, let's say, you want to know the risk of uh, you want to know the you want to study the this esophageal carcinoma. Okay, and you want to know what are the certain risk factors of the esophageal carcinoma, right? So you will select the individuals who have the esophageal carcinoma, which are the cases, and then you select all the individuals who do not have the esophageal carcinoma, which are the controls. And then you will check for the exposure status, whether they have the history of alcoholism, whether they have the history of smoking, whether they have the history of GERD, or whether they do not have any history at all. Then you will again go in the same way for the controls. Okay, whether those individuals who do not have the esophageal carcinoma, they have the alcoholism history, or they have the smoking history, or they have the history of GERD, or they do not have any history at all. Okay, then you select one exposure, let's say the smoking, because you want to know whether the smoking is associated with the esophageal carcinoma or not. Then you will compare the odds or the incidence or the prevalence, I must say, Okay, so you will check the prevalence of the smoking in the disease group, which is the esophageal carcinoma group, or the control group, which is the individuals without the esophageal carcinoma. So you will compare the rate of exposure or the prevalence of the exposure. Okay, so in case of a this cohort studies, what you are knowing is the incidence of the certain disease or the rate of a certain disease. Okay, but in case of a case control study, you want to know the rate of exposure. Okay, in case of a cohort study, you want to know the rate of the disease. In case of a case control study, you want to know the rate of exposure, whether a certain exposure is more prevalent in the disease group or not, right? So the researchers are beginning by selecting the patients with the outcome, which are known as the cases, and those without the outcome, which are known as the controls. Okay, and the matching must be done. Okay, both these disease group and the non-disease group, they must be matched for the age, sex, height, weight, and and all other demographics. So demographics of both the patients or both the groups, they must be same. Okay, then the case control study uses the data which is already collected. And the data could be collected by the medical records, by looking at the employment cards, or by conducting the interviews and the surveys. Okay. Then finally, the data is analyzed to identify what proportion of the disease group or the non-disease group have been exposed to a specific risk factor. Okay. Or you want to know the incidence of a risk factor. Okay, and after knowing the incidence of a risk factor, you will compare the incidence of a risk factor in both the groups. And finally, the odds ratio is determined. Okay, for example, a study that aims to identify what proportion of the individuals with the lung cancer with the lung cancer smoked one packet of cigarette a day for 5 years or not. Okay, so you want to know the prevalence of the smoking one pack of cigarette smoking in the individuals with the lung cancer. Okay, and in the individuals without the lung cancer. Okay, so whenever you want to know the prevalence of a risk factor, you will always look for the case control study. Whenever you want to know the prevalence of a certain with the the incidence of a certain disease in the exposed or non-exposed group, you always want to look forward for the cohort study. So what are the advantages of a case control study? Okay, so it will help determining whether the disease is more likely to be sorry, just give me a second. Okay, so advantages, it helps determining whether the patients with the disease are more likely to be exposed to a certain risk factor or not, whether they have a you know more chances of being exposed to a certain risk factor. What is the prevalence of a risk factor in the disease group or in the non-disease individuals? Simply, okay, what is the prevalence of a risk factor in the disease group or in the non-disease group? Okay, and it will also determine how multiple exposures can lead to one outcome. Okay, how multiple exposures can lead to one outcome, versus in the case of a cohort study, you were determining how one exposure can lead to multiple outcomes. Okay, it is always a cost efficient study. Okay, and of course it is also a time saving study. Okay, and it can also be used in case of a rare diseases, for like a disease which exists in one individuals out of 1 million individuals. Okay, so you cannot just select the healthy individuals and then follow them over time and look if they develop the disease or not. You need to select at least 1 million people for one to get the disease. Okay, so it is so you cannot use a cohort study for that. Instead, what you can do, you will select the all individuals with the rare disease. Okay, because it would be easier to recruit the patient with the rare diseases, and then you will compare them with the patients without a disease and look for the exposing status. So it would be easier to use a case control study in the rare diseases than the cohort disease you know study, the cohort study. Okay, and it can also be used in all the diseases which have a very long latent period. For example, let's say if the smoking developed the cancer in like 40 or 50 years, you just cannot follow the patient for 40 or 50 years, right? But instead, what you can do, you will select all the individuals with with the lung cancer or without the lung cancer, and then you can check whether they have the history of smoking or not, or how many years of smoking history or not, right? So it can be used in all the diseases which has a very long latent period, because it would be very much hard to follow all these individuals. Then what are the disadvantages of a case control study? First is the recoil bias. Okay, and recoil bias is especially true when there is a very long time period between the outcome and the exposure. So some patients might forget whether they have the exposure status or not. Okay, so whenever you want to conduct the interview to check whether the patient whether this patient has a history of exposure or not. Okay, so he might be he might forget his exposure, right? And it can lead to the recoil bias. Second thing, the selection bias can also occur. Okay, and the selection bias occur when when the two groups are not very much similar to each other, and as a result, the result that you get doesn't reflect the relationship. For example, lung cancer might be caused by certain kind of mutations, for say. Okay, and sometimes these lung cancers can also be inheritary, right? And if the two populations are so much different, then you cannot determine whether the biological differences or whether these smoking history is actually causing the lung cancer or not. Okay, so always for these case control studies, the two groups must be similar to each other. Okay, to prevent this thing, to prevent the selection bias. Okay, and you also cannot determine the prevalence or the incidence of a certain disease with the help of this case control study. Okay, and the matching is done to reduce the selection bias. Okay, very much important. The matching is done to reduce the selection bias. And then an example, when you want to determine the link between the cervical cancer and the human papilloma virus exposure. Okay, and you need to compare the similar patients, okay, with and without the confirmed cervical cancer. Okay, so first you select all the individuals with the history of the disease. Then you go back, look in the records, and check whether they have the exposure status or not. Okay, so any doubts so far on the case control and the cohort study? I hope you know the difference between these two studies, when to use the cohort study and when to use the case control study, right?
Can you just please repeat the example which you have wrote about HPV
Can you repeat this
exposure?
again, please? I think you have some network issue. Please repeat it again.
In the last, you have quoted the example between matching groups with exposure to HPV and cervical cancer.
Okay, you
Can
just want to
you
know.
just please repeat this example?
Okay, you just want to
Yeah,
know
this matching
that.
exposure.
Yeah. Okay, let me. Okay, see, you want to know whether the human papilloma virus exposure is associated with the cervical cancer or not, right? So what you can do, you will select all the individuals with a confirmed cervical cancer and the individuals without the confirmed cervical cancer, right? Then you will go back in the time and you will check for the exposure status by the human papilloma virus, whether they have been exposed with the human papilloma virus or not. Then you can easily determine the link between the cervical cancer and the HPV exposure. And you also need to do the matching. You want to compare the similar patients always, because if the patients are not similar, then the cervical cancer can also be caused by the genetic mutations, right? It can be inheritary, it can be due to other biological influences also. Okay, so if you take the if you take the groups which are not very much similar, then you cannot determine whether cervical cancer is caused by the biological differences or by the HPV exposure. Okay, so if you want your study to be a success one, you always need to you always need two groups which have a very similar traits like age, sex, or and the other demographics also. Okay, very important to know. You always want to do the study on similar groups, not the differences. Okay,
I have a question.
please ask.
How can we differentiate the retrospective and the case control?
Retrospective in the case control. Whether
Yeah, like how can I differentiate if at all there is a question, like how can I differentiate if this is retrospective cohort or this is case control? Like both we have to go back, right?
yeah, but we have to go back in case of a cohort study. We are going back to determine the exposure status, right? We want to know whether the patient is a smoker or not, or whether the patient is having a exposure to the human papilloma virus or not. But in case of a in this and 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 right now you do not know whether the patient has the outcome or not. Okay, in case of a cohort. But in case of a case control study, you want to go back looking for the exposure status by knowing that right now the patient is having the disease or not. Okay, you must know the outcome in the present in case of a case control study, and you must not know the outcome of the group in case of a cohort study. If you know the outcome, then it must be the case control. If you do not know the outcome, then it must be the cohort.
Okay, okay. Thank you.
Yeah. So any other doubt? And mostly when you encounter any kind of a case on this cohort on the case control study, most oftenly, you know, they will give you a this study, the prospective cohort study, most of the time, and very rarely they will give you this retrospective cohort study. Okay, but just be careful. If you know the outcome, then it must be the case control. If you do not know the outcome, and you must not know the outcome for this cohort study to be a successful. Okay, very much important to know. Okay, so any other
Uh,
doubt? Yeah.
is there matching is done in the prospective study only, or it is done in retrospective study? Because often the retrospective study we look from the point to backward, where we had no control, like we don't know what had happened, and we just try to analyze the things. Am I right?
Didn't understand your question. If you can please repeat it again.
I mean to say, is the matching or is
It's
something
matching, yes.
we do in the prospective study only, or we do in retrospective study also? Because case control or matching we do in prospective only, because when we go retrospective we don't know what had happened. Am I right?
Matching is always done in both the studies. It is very much required in for both the studies. Okay. See, like I told you, a single disease can be caused by multiple risk factors, right? And a single risk factor can cause multiple diseases, right? So both things can be happen. If you want to know which risk factor is associated with which disease, a specific one I'm talking about, then you must do the matching so that you can easily eliminate other risk factors for the disease, right?
Yeah.
That's why the matching is always required for both the cohort and as well as the case control, because you want to ultimately, you ultimately want to know the association between the two things only, one risk factor and one disease. No other thing should be influencing your study, right? And for that, you always need to do the matching.
Case control is something like we already classified two groups, where there is one group is in experimental group and another group is like placebo or something. We are not intervening like
Yeah,
the.
yeah,
So
exactly.
how will do in retrospective study case control?
Matching
No, like case control.
case control in case control in
Retrospective.
retrospective study. Well,
Yeah.
case control is always retrospective. It can never be prospective. Case control. It
How?
is all. I didn't understand it completely. Your question. Please repeat it again.
How? How we can do case control in retrospective study?
Case control is always done in retrospective studies. Well, I told you already. You will select the cases first, right? Whether the patient has a disease status or not, and then you will go back in the time to check for this exposure. Is that what you're asking?
No, like I mean to say, the case control is something like some incidents had already happened, like some
Yeah,
something
exactly.
already happened, and then
Yeah.
like after 1 year, like now we can see that what had happened with the COVID in last year, which got vaccinated. So in
Yeah.
that scenario, how can we do the case control? Like how we'll make the case control? Like we can do prospective study and then retrospective data collection. In that we can do the case control. But if we are now present and then we are looking retrospective study, then how can we do case control? That I couldn't understand.
I'm seriously not understanding your question. If you can please write it in the chat box, it would be much easier for me to understand. I think you're confusing something with other things. Please write in the chat box so that I can easily know what you're asking. While case control is always done in the retrospective study, that's the same thing I was saying in the whole time. Okay, case control is always a retrospective study. It can never be a prospective study. You always need to go back in the time to determine the exposure status. You cannot go forward in the time to determine the exposure status, right? Both the disease and the exposure has already occurred, and now you want to check whether the exposure was there or not. Case control is always retrospective. Is that what you're asking? I mean, we can discuss this later if you want after the class. Okay, we will discuss this later after the class. Okay, so any other doubt? Please ask.
No.
Okay. So we are done with the case control, cohort, and the cross-section studies. Okay. Whenever the forward in the time is given or the backward in the time is given, you can easily determine whether it is a case control or the cohort. Whenever the time period is given, you can easily know that it is not a cross-section study. Whenever the time period is not given, you're doing the study in the present time and looking at the present thing only, then you can easily know that this must be the cross-section study, not the case control or the cohort study. Okay, it is very much important for you to know the difference between all these three studies. Okay, then let's go back to the first aid and let's talk about the twin coordinates study. It is a kind of a study where you want to know the association of a set. Yeah,
Could you please go back to your page? Can I missed taking a picture. Can I take a picture of that your explanation,
I
please?
will share the file in the group. Don't worry about it.
Okay, thank you.
Okay. Okay, now comes the twin coordinate study, which is a kind of study in where you do on the twins, of course, and you want to know whether the twins develop the same disease or not. Okay, for let's say a twin. Please turn off your mic. Who is that? Okay, good. So you want to know whether if one sibling has a disease, the other twin can develop the disease, same disease or not. Okay, so it could be done by the twin coordinates study. And in this study, you want to determine whether a certain disease has hereditary nature or the environmental nature, whether disease is hereditary or whether a disease is controlled by multiple influences or not. Okay, so this is done with the help of twin coordinates study. Okay, then comes all the these the experimental studies, and first one is the crossover study. Okay, in case of a crossover study, both the cases and the control, okay, they can work as each other. Okay, the case can work as the case as well as a control for itself. Similarly, the control can work as the case as well as a control for itself. Okay, so in this study, what you're gonna do, you will take two groups. a group A individual and group B individual. Matching must be there in both the groups, of course. Okay. Then for the group A individual, let's say you have given just a placebo treatment, nothing else. For the group B, you have given them a certain drug you want to experiment on. Okay. So for the group B, you have given the drug. For the group A, you have given the placebo. Now, what's gonna happen after some time? Okay, you will stop the drugs between the two groups. Okay, and this is known as a washout period. And now you will switch the groups. Now for the group A, after some time, you started giving the drug, and for the group B, you are starting giving the placebo. Now you can easily compare all the results in the group B, okay, between when they've given the drug and when they have given the placebo. You can easily compare the effects in the group B itself, and as well as similarly in case of a group A, you can easily compare the results, okay, in between the placebo treatment and the drug treatment, right? So the group A is acting as a placebo or the control group as well as the case group for itself. Similarly, the group B is acting as this case group as well as the control group for itself. And you can also compare the effects between the group A and group E by comparing these two groups. Okay, so you can either compare the group A from itself or group B from itself, or you can also compare the group A from group B. This is your cohort study. This crossover study. Okay, and this washout period is must required. Okay, in both the groups. Why this washout period is required? Can anyone tell me?
So it won't affect the result.
Okay, to eliminate the confounding, you can say, right? To eliminate the every effect of the drug or the placebo, so that you can easily eliminate the confounding. Okay, so and that's why this washout period is required. Okay, easy to understand. The crossover study, that important study, and then comes our adoption studies. Okay, and in this you will compare all the differences between the siblings, which are the biological as well as the adoptive parents. Okay, and you also want to know whether a certain disease is hereditary or has some this environmental factors or not. For example, let's say an obesity. Okay, you have a family in which all the members are obese, and and then one member in this family who is adopted, he's not obese. So now you want to know whether this obesity is hereditary or has some environmental influences. Okay, so we'll select the families who have this adopted child in these families, and then you will look for the outcomes. Okay, this is the adoption study. So for the twin coordinate study and for the adoption study, you want to know whether a certain disease is hereditary or a disease is controlled by the environmental influences or not. Okay, these are the two studies. So any doubts so far?
No.
No.
Okay. This is a design for the case control study. Okay, now we're going to discuss the incidence and the prevalence.
Can you show that again?
Can I show that?
Can you show that the previous picture, case control?
This one?
Yes, thank you.
Okay, so yeah, now we're going to discuss the incidence and the prevalence. Incidence is the new cases, the number of new cases which are added to a certain population at a given period of time. For example, you want to study a population for 1 year, and in this 1 year, how many new cases are added? This is known as the incidence. Okay, and for the prevalence, you want to know how many cases are at this point of time is present in the population. Okay, so total number of cases which are present in a population is known as the prevalence, and the number of new cases which are added to the population is known as the incidence. Okay, And the formula for the incidence is basically the number of new cases divided by the total population at the risk. For example, in case of let's say the malaria or the smoking you want to know. Okay, so how many new cases of smoking added in the population of smokers? This came upward. Okay, and let's say you already have you have a population of 1,000 people. Okay, and about 100 people already have the cancer. So now you will exclude all the patients who already have the cancer. Okay, and in this part you will have what? The 900. Okay, so the new cases divided by the population of the risk. You have eliminated the 100 individuals which have the cancer, so only 900 are at risk. So these are the population at the risk. But in case of a prevalence, you will take all the existing cases at the point of time, including the previous one and the new one, and you will divide them with all the individuals in the population, the total number of individuals with the population. Okay, at the risk or already have the cancer. Both are included. Okay, so this is the incidence and this is the prevalence. Okay, and then you must know this formula, which is prevalence divided by 1 minus prevalence will be equals to the incidence rate multiplied by average duration of the disease. I've encountered one question on this formula. I think MBOS has this question on this formula, so you must need to know this formula also. Okay, and how you can say that the prevalence is equals to the incidence. For example, there is a disease which has a very short course. Okay, like 2 or 3 or 4 days, for example, like common cold. So the number of new cases are being added, okay, will be equals to all the cases which are already present, because now the patients are recovering at a very faster rate. 10 cases are added, 10 patients are recovered, so only the net remaining cases will be 10, right? So this is the case. Whenever a disease has a very short duration, you can easily say that the prevalence will is approximately equal to the incidence. Okay, then comes for a long existing diseases, let's say the diabetes or the hypertension or the cancers. Okay, the prevalence is always greater than the incidence. Okay, very much important to know that. And whenever the prevalence is increased, you will always have an increased positive predicted value and a decreased negative predicted value. We have discussed this in the previous lecture already. Whenever the prevalence is increased and when a certain test gets a positive result, you can easily say, because the prevalence is very much high in the disease, that means the test must be right. But if a disease is very rare, okay, and your test got a positive result, you can say that without doubt, then this might be a case of the patient, right? Or the patient might be a normal one because the disease is very rare. Okay, and in a very highly prevalent disease, if the test got negative, then you can easily say that this can be a false negative because the prevalence is too much in this population, right? Okay, then comes certain scenarios. Whenever you have an increased survival time from a disease, okay, for say the diabetes, there are lots of treatment available for the diabetes now, and the patients are not dying anymore. Okay, so what's gonna happen? The duration of the diabetes is increasing. So as a result, the incidence, it won't gonna have any effect on the incidence. It will always remain normal. But the prevalence, because new cases are being added, and the previous cases they keep on accumulating in the population, right? So the prevalence of the disease is increasing. Whenever the mortality of a certain disease is increased, then the prevalence of the disease will be decreased, because all the existing cases are now eliminating from the population by the death. If the disease has a very faster recovery rate, then again the prevalence must be decreasing. Okay, if you do the vaccination, then the incidence would be decreased as well as the prevalence would be decreased. Okay, for example, if the step 1 will ask you, okay, what is the most effective way to decrease to decrease the all the let me made up an example. If the step 1 asks you that what is the most effective way to decrease the risk of having a hepatitis C virus, oh sorry, not the hepatitis C but the hepatitis D virus, okay, what is the most effective way to decrease the incidence or the prevalence or all the patient with the disease with the hepatitis D virus? So you can vaccinate all the patients with the hepatitis B virus vaccine, because you know that the hepatitis B virus is required for the infection by the hepatitis D virus, right? So if you vaccinate the patients with the hepatitis B virus, then you can easily decrease the incidence as well as the prevalence for the hepatitis D virus, right? So note this fact. Okay, if the risk factors are decreased, then incidence must be decreased. And of course, if the incidence are decreased, then the prevalence will also be decreased. Okay, so any doubt in the incidence and prevalence?
No.
That survival time, can you say that?
What?
Increase in survival time will cause no change in incidence. Why is that?
If the survival time is increased for, say, we'll take an example of a cancer, a lung cancer. Okay, let's say initially the lung cancer has no treatment, and the patients were dying at a very faster rate. Okay, like 5 year survival or 6 year survival. Okay, incidence was same. And say an example, like for 1 year, in 1 year, the 10 cases of lung cancer are being added to a population, right? 10 cases of lung cancer are being added to a population. Okay, now because the survival time initially is very low for 5 or 10 years, the prevalence of the disease is low, right? Because all the patients are keep on dying with the disease. But now all the treatments of the lung cancer are now available. Okay, and the survival time for the lung cancer is now 50 years. Okay, not the 10 years anymore. So what's going to happen? The incidence will remain same. The 10 patients per year will keep on adding to the population, right? But now what's going to happen? All the patients with the disease, with the lung cancer, who were dying for like in 5 or 6 years, now they will have the disease for 50 or 60 years. Okay, and these 10 new cases will be keep on adding to the population. So what's going to happen? The prevalence will increase, but it has no effect on the incidence. It will always remain 10 or 20, right? So increasing the survival time will only increase the duration of the disease, not the incidence. If you increase the risk factor, if you increase the smoking, then you will increase the incidence. Okay, but the risk factor is same. You're just having a lots of treatment available. You are increasing the survival time of a disease. That means only the prevalence is increasing, not the incidence, right?
Yes, I got it.
How would vaccination reduce prevalence?
Okay, if you do the extensive vaccination, then what's going to happen? Let's say, for an example, hepatitis B virus vaccination. Okay, and like I told you, the hepatitis B virus is required for the infection with hepatitis D virus. If you do a lots of vaccination for the hepatitis B virus, then you can also never get the hepatitis D virus, right? So what's going to happen now? The new cases of the hepatitis D virus, they will decrease. And if the new cases are decreased and the previous one are keep on treating in the population, okay, they have a faster recovery rate, then what's going to happen? The prevalence will also decrease. So whenever you do a vaccination, like say in case of a COVID, we are saying that the vaccination is the only solution of the COVID, right? Because with the vaccination, you no longer can have a new cases. So the incidence will be decreased, and the previous cases, they all will recover in the time, and as a result, the prevalence will also decrease, right?
But the number of existing cases won't change, right?
The number of existing cases, they will recover, right? After some time,
In case
like
of
10,
hepatitis,
15, 20 days.
like in
Yeah.
the earlier like in the previous example of hepatitis B,
Yeah.
if you vaccinate the people, so there will be no new cases. But what about the cases that are already there?
You know, the hepatitis B has a 95% recovery rate. Am I right?
Yeah.
So they
Yes.
all will recover after some time, and the prevalence will be decreased.
They recover earlier.
Yeah, exactly.
But vaccination didn't play a role in their recovery, right?
Vaccination, yeah, no doubt, no role in the recovery, but you are no longer adding new cases to the population. And if you are no longer adding new cases to the population, then the prevalence will be decreased, of course. Let's
Okay,
say
so
you
we
do
can
not
take it
vaccinate the
like
patient.
this.
Let's say a population of 1,000 individuals, and 500 of them have the hepatitis B virus. Okay, 500 are normal, Now what can happen, every year 50 patients will be added to this population of the diseased group from this population, right? Now what you did the vaccination. Okay, now no longer new cases will be added to the population. So those 50 who were adding every year and increasing the prevalence, they are gone now, right?
Okay.
They were they were actually contributing in the prevalence, and now they are gone. So they no longer can contribute to the prevalence, and ultimately they will recover. Okay, and the prevalence will be decreased. So by decreasing the incidence, because you are no longer adding the new cases, you will decrease the prevalence also, right?
Okay.
And then comes the precision and the accuracy. The precision, it has it is also known as a reliability. How you can remember this? Both has PRE. So this RE for the reliability. Okay, so precision and the reliability, they both are the same thing. Accuracy and validity, they both are the same thing. Now, precision is basically when you do a test on a certain patient repeatedly, okay, how often it get a result, are very close to each other. For example, let's say you want to do a test for the myocardial infarction, okay, and you know that whenever you got and in the myocardial infarction, you want to know the level of this troponin, right? So you run the test in a patient, and at one time you get a troponin level of 200 in the myocardial infarction. The second time you get a troponin level of 210. The third time you run the test, you got a troponin level of again the 200. So now you can see these values are very close to each other. And now I can easily say that the test is a very highly precise test, because every time it is giving me a values which are very close to each other. Okay, so I can say that I can easily rely on this test. So this is the precision and the reliability, how close the repeated measurements match to each other. This is the precision. Whenever a random error occur in a certain test, okay, it will always decrease the precision of the test. By the error, you can decrease the precision of the test. And once you increase the precision, now you are getting a values which are very close to each other, like 200, 210, and again 200. So you can easily say that the standard deviation is now decreased, because standard deviation is a difference between two different values, right? And because the difference is now very much low, you can easily say that the precision is increased. So whenever you have a decreased standard deviation, you can have an increased precision, right? Am I right?
Yes.
Yes.
Okay. And all one more thing, all of these are random errors. They all are the errors which are occur by the chance. All the errors that you study here, the bias and the study errors or the systemic errors, I say, they all can reduce the precision of the test. Okay. And whenever you increase the precision of the test, now you can easily increase the statistical power. Okay. Whenever for example, whenever you increase a sample size, let's say, because you know that on increasing the sample size, you can easily increase the power of your study. And same time, by increasing the sample size, you can get a many different values. Let's say for initially you were getting a values of 200, 250, and 280. Okay, that was a difference between three values. But when you run the test for like 50 or 60 values, you were started getting many of the values, like say 90% of the values at 200 only. See, you okay? Are you getting my example?
Please repeat it.
Let's say initially you run the test for only 3 times in a patient, okay, and you get a value of 200, 280, 250. Now you can see that all these values are so much different from each other. And by looking at three values, you can say that a test is a very high, this test has a very low precision, right? You can say that. But let's say when you run the test for 50 values, okay, for 50 times you run the test, and after these three values, you're getting all the values near 200. Yani ki, that means most of the values, almost 95% times you are getting the values between 200 and 205, let's say. So now you can easily say, because most of the values are lying in between 200, 205, 95% of values, only 5% of values have this 250 or 280 number. You can easily say that this test has a very high precision. So whenever I increase my sample size or whenever I increase my statistical power, my precision is also increased, right?
Yes.
I think you understand this now. Okay. Okay, so now, sorry guys, I have, okay. Remember I told you about these errors. Okay, these errors, they do not affect the precision, but actually they affect the accuracy. Okay, precision is affected by the random error. Okay, and you decrease the random error by increasing the observation number. Like I told you, if you increase sample size, you can increase the precision. Okay, the example I've given you already. So if you increase the number of observations, you can get a high precision. Okay, to decrease a random error, you need to increase the observations, repeated measurements. So a random error can decrease the precision of the test. Okay, and to decrease a random error, you need to increase the observations. Now comes the accuracy. Okay, and it tells you how close the values of my new test are to the gold standard test. For, let's say, there's a gold standard test for the level of troponin in the body of a myocardial patient. Okay, and let's say the gold standard test was showing the value of 200. Okay, so from this gold standard test, you can easily say that a patient with the myocardial infarction has a troponin value of 200, and it is accurate. Okay, now you develop a new test for the same troponin values, and now you are getting a values of 205, 208, and 210. Now you know that these values are very close to 200. Okay, so you can easily say that my test has a very accuracy to the existing test, or my test has a very close values to the existing test. As you can see here, all these values which are in the center, you can say that my test is a very high accuracy because all the values are lying at very accurate site, which is the center. Okay, and whenever you have a systemic error, all the errors that you will study in the next pages, the attrition bias, the selection bias, the confounding, and everything, they all will decrease the accuracy of the test. Okay, and all the sensitivity, all the specificity that you have studied previously, all of them are the measures of accuracy. Okay, how accurate your test is in determining the status of the patient, how close your values are. Okay, so now look at the examples. In the example one, you can see that your test has a very high accuracy because all the values are lying very close to the original test. This is a center, and it shows that the values are very accurate to the original test. Okay, you can easily see that all the values are very close, and because different values are very close, you can say that the test has a very high precision. And at the same time, the test also has a values which are very close to the previous test. Okay, that means you can say that a test is also a very much accurate, so a very high accuracy and a very high precision. In this second example, you can easily see that all these values are a very much away from the gold standard values, right? So my test, it do not have any accuracy at all, but all the values are lying very close to each other. That means my test has a very high precision. So low accuracy but high precision. Similarly, in this third example, you can see that my values, most of the values are lying very close to the center. That means test has a very moderate or a very high accuracy, but all the values are lying very different from each other, right? That means my test has a very low precision. Okay, in this last, for example, you can see that all the values are lying very far away from the center of the gold standard value, right? That means my test has a very low accuracy. And because all these values are very different from each other, that means my test also has a very low precision. Okay, so any doubt on this accuracy and precision?
Could you please repeat the one of
What point?
of the precision on high accuracy? How is it high accuracy when the targets are scattered around the circle?
Okay, see, this is can turn
I
off your
got that
mic.
one.
Yeah.
Uh-huh. This one is
See,
okay.
okay, yeah. You want on this one, right?
Yes, I understood this one.
Okay,
Then
see.
this one is the next one.
Yeah, okay. Now see, this is a value which is a value of the gold standard test.
Correct.
Okay, just like, okay, so this is the value of the gold standard test. Okay, and this is all the distance. Okay, all the distance of different values which you're getting away from the gold standard test. If you get a value from here, that you can see that your the value of this new test is a distant has a distance from the gold standard values. For let's say this center represent a 200 level of the troponin, and this represent a 230 level of troponin. This represent a 260 level of a troponin. Okay, see, now if you run the new test and 200 is the accurate value, which is the real value of the patient having a myocardial infarction. Okay, now you run the new test and all the values you are getting is near 200, like 201, 202, 203, right? Now you can easily say, because all the values are very close to 200 or very close to the center, you can say that your test has a very high accuracy. And because all the values are in 201, 202, 203 range, that means all the values are very close to each other. You can say that your test also has a very high precision. But in this case, because your values are lying to 260, but the real value is 200. Okay, so it has a very major difference between the values. You can say that your test has a very low accuracy, because it is measuring the level very different or very falsely, right? So your accuracy is low, but all the values are like 260, 263, 262, 265 are very close to each other. You can say that your test still has a very high precision. You understand it now?
Yes, thank you.
Okay, so any more doubt?
How is it possible for a test to be highly accurate and yet not precise? The third number example.
Highly accurate but not very precise. For example, there is a test who is showing the value of 200, but the real value of the troponin was 200, but the test is showing you a value of 200, 205, and then 230, 240. Okay, no, not that example. Let's say you have a test, and for the gold standard test, the value of the troponin was 200. Okay, now you run your test and the values you are getting are like 195, 205, okay, 190 and 210. So you see the values are very close to the center, but they are far away from each other. A difference of 10 or 20s are existing, right? So you can easily say that your test is not very precise but a very high accuracy, because they're kind of a very close to the center, a very close to the these gold standard values. Okay.
Okay, I get it. Thank you.
Yeah. Any more doubt?
No.
Okay. We should take a short break here for now, and then we will meet again after 10 to 15 minutes. Okay.
Okay.
Yep.
Resume the recording. Okay. One more thing. When the step one gives you a period of time, okay, so what population you should take at the people of risk? Okay, what population, what number of individuals you should take for these people at risk? Let us suppose there's a population of 1000 people and 100 of them had the disease already. Okay, and when you started the study, 100 people already had the disease. Okay, and then after 1 year, which is a study time, 10 more patients got the disease. Okay, so what population would you take for the people at risk? It is 900 or 890?
900?
Exactly. You will always take all the people at the very start of the study. Okay, so whenever the step one gives you a question of incidence, don't forget you should take the people at risk at a very start of the study. Okay, not at the end of the study. Okay, because that's when your study is already started. Okay, don't forget this thing. Okay, then the ROC curve, which is a receiving operating characteristic curve. The only thing that you need to know on this curve is, the higher the area under the curve, better is your test. Okay, so what step one gonna do? They will give you this kind of a graph, okay, of different tests. Okay, and they will ask you which test is best. So the test which has a highest area under the curve, the test would be best. Okay, you already know the 1 minus specificity versus the sensitivity. This is the LR positive, right? If you divide this, if they ask you what is the slope of the graph, which is the height versus the base, this is the sensitivity divided by 1 minus specificity. What would you get is the likelihood ratio positive. So this will be the slope of the graph, right? And yeah, so the test which has the highest sensitivity and highest specificity, this must be a test which has the highest area under the curve. The only thing that you need to know from the ROC curves, okay? No other thing. Okay, then comes the systemic errors or the bias and the other study errors. Okay, one is the bias which is going to happen while you're recruiting the participants. Okay, and the first thing is the selection bias. Selection bias occurs when the participants that you have selected does not represent the targeted population. Okay, let's say you want to know all the individuals with the history of lung cancer. Okay, and you're selecting the individuals. You want to know all the individuals with the history of smoking and those who got the lung cancer. Okay, but you're actually selecting those individuals which work in the coal mines and has a history of cancer. So it will deflect your disease, right? It will deflect your it will deflect your study, right? So it can lead to the selection bias. So you should always take only those individuals which represent a targeted population. Okay, so this is known as the selection bias. Or let us suppose there is a population which has this much area, for example, right? And you're selecting all the individuals and you want to study this population as a whole completely, but you're actually selecting all the individuals from this locality only, from this much area only. So this much area actually do not represent the whole population, right? But you're actually and all the study things, all the data that you will get from studying this population from this area only, you will apply this data to the whole population, which is actually not true, right? It would be wrong to do that, right? So that's how you can get a selection bias. You need to select a certain individual from this area, certain individuals from this area, certain individual from this area, from this area, and from this area, so that you can get a data which is representative of all the population, right? But instead, what you are doing, you are only selecting individuals from this area only. So that's how you can get a selection bias. Okay, so a selection bias occurs when the selected population actually do not represent the targeted population. Okay, when the two or sometimes when it can also be happen when the two groups they differ in other characteristics also. Like I told you, you always need to do the matching, right? Otherwise the two groups that you will create, they will be differ in other characteristics also, other demographics also. Okay, and that's why you can get the selection bias. It is also known as an assessment bias. Okay, they can give you either of the name, the assessment bias or the selection bias. Okay, the one way is the Bergson bias. Okay, when you select the cases or controls from the hospitals, which are often very less healthy, and then you will apply the traits of this hospitalized patient to the other populations also. The same thing that I told you, that there is a whole population and you're selecting all the cases or the controls from a small group of patients. In this case, these are the hospitalized patients. And all the hospitalized patients, they are generally less, less healthy and very much ill. And once you study the population from the healthy individuals, then you apply these traits to other population also. So you will get a wrong results, right? Because all these hospitalized patients, they different other exposure also from the general population. So you will get the Bergson bias. Whenever you take either the cases or the controls from the hospitals and the other one is the general population and you compare these two things, so you're going to get a Bergson bias. Okay. Second thing is the attrition bias. What's going to happen when you do a cohort study and you follow the patient for like 10 or 15 or 20 years, and what's going to happen, some of the patients or some of the individual will lose the follow-up. Okay, and as a result, what's going to happen, your sample size will be decreased. Okay, now if if there's an exposed group and there's a non-exposed group, okay, and the equal individuals or the random individuals from the exposed group are lost, for let's say there are like 100 individuals in the exposed groups and 100 individuals in the non-exposed group. Okay, and 10 individuals randomly from the exposed group is lost, and 10 individuals from the non-exposed group randomly are lost. Okay, so then in this case you won't get the attrition bias, because from both the groups the sample is kind of attrition. Okay, but it is happening kind of randomly. Okay, so it won't affect ultimately your study. Okay, it won't affect the data of your study. But now let us suppose you have an exposed group for the smoking and you have a non-exposed group for the non-smokers. Okay, and let us suppose there are kind of 100 people who are smokers and 100 people who are non-smokers, out of which let us suppose originally 30 or let us say the 20 individuals got the cancer, lung cancer. Okay, and in the non-exposed group, let us say 5 individuals got the cancer. But due to the attrition bias, let us suppose 15 patients who got the cancer are lost to follow-up, or either they are dead. Okay, so out of the 20 individuals from 100 who got the cancer, 15 lost the follow-up somehow. So now your study will say that out of the 100 individuals, only 5 developed the cancer. It is look like only 5 got the cancer. Okay, and you can say that smoking is not associated with the cancer, but the non-smoking is associated with the cancer, right? So it will ultimately what going to do, it will cause an error in your study. So this is the attrition bias. So it will happen when the non-randomly the participants of one group lost the follow-up. Okay, so ultimately your study will will be deviated to one side only, because the balance is lost now. And whenever the balance is lost, you will get the attrition bias. Any doubt in the attrition bias? Should I repeat it again?
How attrition bias is a type of selection bias.
Yeah, attrition bias is a type of selection bias, you want to ask.
Yes.
Because actually you're selecting, let us suppose you're selecting all the individual, let me make an example for you. Let us say you're selecting all the individuals which have a history of smoking for 5 or more than 5 years. Okay, so the exposed group contains all the individuals which have a smoking history of 5 years, 10 years, 20 years, 30 years, right? The individuals which have a smoking history of 30 years, they will get the cancer more rapidly. Okay, and they will lose the follow-up. Then there are individuals who have the smoking history of 5 years, they will develop the cancer very slowly, and after that they will lose the follow-up. So ultimately what's going to happen, once you follow the individuals for like 5 years, most of the individuals which have a smoking history of 20 or 30 years, they will be lost, and you cannot include them in your data sheet. Okay, that's why it is a kind of selection bias. So you need to select only those individuals which have a smoking history of 5 years, not more, to reduce this. Okay.
Okay. It
Oh,
means
yeah.
selection bias depends upon our initial selection of these subjects, right?
Yeah, exactly. It is always dependent upon the initial selection of the subjects.
Okay.
Okay. And the other example, if you want, you can take for a let's say you are making a drug for the chemotherapy, right? And you're selecting all the individuals. Let's say for a certain type of a cancer, let's say the esophageal carcinoma. Okay, you're selecting the grade 1, grade 2, grade 3, grade 4 cancers patient, right? Now what's going to happen, all the grade 4 patient, they will be die very soon, even after taking the drug, because grade 4 is very harder to treat. Okay, so they will be lost from the study, and ultimately you cannot include with their data in the sheet, and it will look like that your drug is kind of very much and let's say out of the 100 individuals, almost 80 individuals are of grade 4 cancer. Okay, and only 20 patients are there who have the grade 1, grade 2 or grade 3 cancer, right? So it is looking like the drug is kind of non-effective, because out of 100, 80% are dead, right? So it is making the study look like that your drug is actually not working, but it was actually because of the selection bias, because selecting all the individuals which have a grade 4 cancer. But what you should do initially is to select 20 individuals from the grade 1, 20 individuals from the grade 2, only 20 from the grade 3 and 20 from the grade 4. So if you do the right selection, you will get the right result. If you bias your selection to one side, like in this case, a grade 4 cancer, you will get the error in the result. I hope you understand it this way.
Yes, I do.
Okay. And whenever the question stems says that there is a volunteering for the subjects, okay, that the subjects are allowed to volunteer themselves, that means they're always going to talk about the selection bias. Whenever they ask you that that the selection is based upon the volunteering of the subjects, all the subjects who want to volunteer, they can come into the study, then it is always going to cause the selection bias. Like I told you, that all the individuals who have the grade 4 cancer are more likely to volunteer themselves for the study because they want to be treated with this new drug, right? So whenever the volunteering is there, it will always cause the selection bias. You need to select the individuals according to yourself, according to your study, not according to the patients, right? So that's about the selection bias. Then comes all the errors which can happen while performing the study. And the first one is the recall bias. Recall bias only occurs in the retrospective studies, whenever the interviews are conducted to know the exposure status, and when and when there's a very long period of gap between the exposure status and the outcome, then all the individuals who do not have the outcome, they are more likely to forget the exposure status. Like say, for a lung cancer, if you select a patient with the lung cancer and without the lung cancer, and you want to know the history of smoking, so all the individuals who have the lung cancer, most of them will recognize their smoking status. But the individuals who do not have the lung cancer, they are less likely to recognize their smoking status. Okay, so that's how a recall bias can generate, and it will make the study look like that smoking is a cause of cancer, although it is true, but it is kind of deviating your result in a one way, okay, towards the smoking more, right? So this is the recall bias. It will deviate your data. It will manipulate your odds ratio ultimately, because it will look like the odds of the smoking are much higher in the lung cancer group than the non-lung cancer group. But in the real life, it is kind of not true very much, right? So it is generally occur in the survey studies or in the studies where you want to conduct the interviews, most oftenly in the case control studies. Okay, so it is a bias that occur in the measurement of the exposure status. Okay, and this recall bias can cause the misclassification bias, because ultimately in the case control study, you want to you want to categorize with the individuals on the basis of smoking status later, right? Either they have the exposure or they do not have this exposure, right? So ultimately, if they do not recall their exposure status, what's going to happen? Misclassification. You will misclassify them in the non-exposed group. Okay, so a misclassification bias can occur in case of a recall bias. Any doubt in the recall bias? Please respond. Recall
No,
bias.
no, no.
Okay. Then comes the measurement bias. Okay, when the information that you gather during the study has some kind of a error, and uh, or the study that or the measurement that you gather, is in a very distorted manner. Okay, and it always happens when the protocols are not followed. Okay, like say, for a BP measurement, you are using the same BPP cuff for the old age individuals, for a large size individuals, and for the kids. Then what gonna happen in case of a very large size cuff? It will accurately measure all the old age or the patient who have a very large size. Okay, but for the childs, for the infants, it will measure the baby very inaccurately. Okay, so it will create a measurement bias. And why it happened? Because the protocols are not followed. You should use a separate BP cuff for the infants, for the childs, and for the older individuals, right? So this can lead to the measurement bias. Okay, second thing is the Hawthorne effect. Hawthorne effects occur when the study participants knows that they are being observed or they are being studied. So ultimately what going to happen? They will change their behavior as soon as they know that what they are being studied. They will change their behavior, and once they change their behavior, it will deviate your data. For let's say, in case of a vaccine, in case of a vaccination, you want to know whether a certain clinic always ask their patient to vaccinate themselves. Okay, initially that clinic was not asking the patient to vaccinate. Okay, but as soon as he realized that he's being under study, the clinic always asks the patient to to vaccinate themselves, and it will make the study look like that this individual, this doctor, or this clinic always asks the patient to vaccinate themselves, right? So it will deviate the data. Okay, for example, you want to assess them for the 100 times, that out of 100 times, how many times they ask the patient to vaccinate themselves. And initially it was just 20, and once they realized that they are being studied, they started asking every patient for the vaccination, and now you're getting a result of 80. So it will make the study look like that they always ask the patient 80 times out of 100 times what they will ask the patient to vaccinate, but ultimately it is not true. It was actually a 20 just. Okay, so it can lead to the measurement bias. Okay, so how you can do the measurement bias? One thing is basically using the placebo group. For example, there's one more thing in the measurement bias, which is the placebo effect. What's going to happen when, as soon as the patient realizes that he's being under the study and he's receiving a drug, he started to manipulating their behavior. Okay, like they're improving the health, even though they're taking the placebo, and because they're thinking that this is the actual drug, they will make their behavioral changes, and it will look like that the placebo is actually working, not the drug, but the placebo is actually working. Now this is the placebo effect. When the patient knows that he's giving a certain kind of a drug, so they will and they will expect a certain outcome, so they will change their behavior. Okay, let's say for a pain control medication, as soon as the patient realizes that he's being under study and he's receiving a drug for the pain control, he will change their behavior, and because of this change in the behavior, they will reduce their pain, their pain psychologically only, right? So this is a placebo effect. So how you can do? First is, of course, a standardization. Okay, the previously tested method should be used, and second is the placebo group use. Okay, but and because if the patient know that he's not being under the study, so he won't do anything. He will say that my pain is getting worse and worse and worse, and all the patients who are receiving the drug, they will try to manipulate their symptoms psychologically, and it will look like that drug is actually working, although the drug was not working at all. Okay, so the use of placebo can eliminate this effect. So this is and the other thing could be the placebo effect. Okay, and yeah, any doubt in the measurement bias?
Yeah, would you repeat the Hawthorne effect again?
Okay, so in case of a Hawthorne effect, as soon as the participant realizes that they are being under studies, okay, they will change their behavior. Okay, like the previous example I gave of an OPD. Okay, and you want to assess the OPD that how many times they will ask their patient to vaccinate themselves. Okay, and let's say you want to assess them for 100 times. Initially, what was the case is, out of the 100 times, they were asking only 20 patients for the vaccination. But as soon as they realized that they are being under the observation, they changed their behavior, and now they're asking every individual for the vaccination. And once your study is conducted, what data you gather is 80 times out of 100 times, 80 times they have asked the patient to get the vaccination. But in actual scenario, it was not true. Actually, they were asking just these 20 individuals individually, right? So it will would deviate the data of the study. You will get the false results, right? The false result of 80, but in the actual it was just a 20. So this is the Hawthorne effect. And similarly, let's say you have a drug for the pain control. Okay, for the group A, you have given this medication, and for the group B, you did not give any kind of a medication. Okay, but let's say this group is not working at all. Sorry, with this drug for the pain control is not working at all. But because the patient in the group A is taking this drug, okay, he will make some psychological changes inside his mind. Okay, and he will think, or he will change the behavior of himself, and it will make him look like the patient, the pain of the patient is actually decreasing. Although the drug in real life is not working, but it will make the study look like that drug is actually working. The pain is actually reducing in the patient. And because the group B did not receive any placebo or anything, they won't change any behavior of them, right? So they do not have any decrease in the pain. Okay, so the study makes it look like the drug is actually working, but it's actually a psychological scenario the patient or the behavior the patient is changing, which make look like the drug is actually working, the pain is reducing. Okay, but it's not because of the drug, but because of the psychological effects. So this is the Hawthorne effect. When the patient know that they are being under the study, they will change their behavior and they will deviate the data of the study. Okay.
Can you give an example of recall bias?
Can I explain the?
Recall bias.
Okay, recall bias occurs whenever you ask the participants to recall their exposure status for like 20 years or 30 years back. Okay, like for example, you selected a patient for the lung cancer or without a lung cancer. Okay, and you want to know whether they have a previous history of smoking or not, like 20 years ago, if they've smoked or not. Okay, because as soon as the patient realizes that they have the lung cancer, well, they will stop the smoking, right? So now you want to know whether in the past 20 years back they smoked or not. Okay, so all the individuals who have the cancer, they are more likely to recall their exposure status, that yes, I smoked in I smoked 50 years back or 20 years back. But all the individuals who do not have the cancer, they are less likely to recall their exposure status 20 years back, especially if I'm asking, right? So it will deviate the data of my study. Yeah.
Okay.
And this is known as a recall bias. Okay. Okay. And yeah, then the measurement bias. Okay, I hope it is clear for all of you, the measurement
Yes.
bias.
Yes.
Okay,
Yes.
then comes the procedure bias. In case of a procedure bias, the group which is under the study, you're treating them differently than the group which is not receiving any treatment. Let's say you have given a certain drug or to a certain patients, a group of patients, and let us call them a group A. And for the group B, you know that this group B is not receiving any kind of a treatment for the pain. Okay, and now you started giving some other things like some special treatment to all this group A patients who are receiving the drug. Okay, and because of these treatments, it is not the drug, but because of these treatments, their pain is actually reducing, like the massages and other thing, and the physiotherapy and other things. Okay, not the drug, but actually this physiotherapy and the massages the patient were receiving in the group A, their pain will reduce. So so the study makes it look like the drug is actually working, but in real life it was the treatment, the special treatment the patients were receiving was reducing their pain. Okay, so it will create a bias, which is known as the procedure bias. Okay, when the subjects in the different group are not treated the same way, the subjects who were receiving the therapy or receiving the surgery or receiving the drug, they will treat in a different way as special treatments, while the group who were not receiving any kind of a treatment, they do not get any special treatment. Okay, so the pain in the special treatment group will be reduced, and it will make look like the drug is actually working or the surgery is actually working. But that was not the true case. It was actually the special scenarios or the conditions the patients were receiving. Okay, understand the procedure bias?
Yes.
Yes.
Okay, then comes the observer expectancy bias. When the observer know that the patient is receiving a therapy, okay, and which group is receiving the therapy and which group is not. Okay, and because of their observer expectancy, they will change their behavior. They will try to kind of they will try to say motivate the patient that their drug will work, that drug will work, don't worry, and because of this motivation, the patient again will change their behavior somehow, right? Or let's say for example, there was a question in the U world, and that say uh, and there was a group of this pathologist which work in the hospital. Okay, and they have a patient from the hospital and they want to analyze the histology samples for the diabetes, let's say. Okay, and then there were other uh, these pathologists which are from the other hospitals. Okay, and they also need to analyze the same data for the diabetes. So all these pathologists which are working in this hospital, the same hospital of the patients, they're more likely to get the data very fastly because they already know the exposure status than those pathologists who do not who are not from the same hospital. Okay, and why this happening? Because the observer who are analyzing the data, they know the exposure status of the patient already. Right, now understand this my example, or should I repeat it
Yes.
again?
Repeat.
Okay, let us suppose there is a hospital. Okay, and in this hospital there are some pathologists. Like say I've selected 5 pathologists from the hospital. Okay, and 5 pathologists from other hospitals. Okay, now I have 5 samples of the diabetes and all the 5 samples are belong to that same hospital A, in which the originally 5 pathologists are working. So these 5 pathologists who are working in the same hospital as that of the patient, they will analyze the data more rapidly because they already know the exposure status of the patient. While those pathologists who are not from the hospital, from a different hospital, they will analyze the data more slowly, right? Because they do not know the exposure status.
Yes, got it. Yes.
Okay, so this create a observer expectancy bias. When the observer knows the the exposure status of the patient. Okay, and this is also known as the Pygmalion effect. Okay, very much important. How you will reduce the procedure bias or the observer expectancy bias? Well, the first thing is the blinding. When the neither the patient nor the doctor or or not the observer who was recording the data knows that what group receiving what treatment. Okay, so first thing is the blinding. Second thing is the use of placebo. Okay, because like I told you, if you do not give any kind of a medication to the other group and you give one medication to the who do the who do the group A, then what gonna happen? Some behavioral changes might influence the result of the study. But if you give the drug to the group B also, which is a placebo group, okay, then because they know that they're receiving some kind of a group, then this group with the placebo group, they will also change their behavior in the same way as the treatment group. So now you can easily eliminate the behavioral changes of both the group, and now you know that only the effect of the drug could be recorded because the behavior changes are are in both the groups, right? So one thing is the blinding. Second thing is the placebo effect. You are actually making the condition very much similar for both the groups. Okay, very important. So I hope you understand this placebo effect and the blinding.
Yes.
Would you repeat the procedure bias?
Uh, the procedure bias. Okay, this bias actually creates, sorry, just give me a second. Okay, this bias actually happens when the groups who are receiving the treatment, they have given a special treatment other than the actual drug. Let us suppose you want to study a certain drug for the pain relief. Okay, you have selected 2 groups, the group A who were receiving the drug and the group B who were not receiving the drug. Okay, the individuals in the group A who were receiving the drug, they have given a special therapy like the physiotherapy and the massages. Okay, and their pain is kind of reduced very much. Okay, and let's say the drug was not working at all, but because of the massages and because of the physiotherapy, their pain is reduced. Okay, and now it will make the study look like the drug is actually working, but it was not the drug, it was the massages and the physiotherapy that were working originally. Okay, so this will bias our results to one side. Okay, and or another example, let's say you want to assess the same drug for the pain relief. Okay, and you want the patient to score on the rate of 1 to 5 on how much the drug is working for them. 5 is for the good and 1 is for the worst. Okay, let's say along with giving the drug, you are also giving the patient physiotherapy and this and the massages. Okay, and all of the patient reports are a result of 5, but in actual the physiotherapy and the massages also contributed in this result, right? And let's say the original effect of the drug was like 3 only. Okay, but the study was deviated to the 5. Okay, and this creates a procedure bias when the study
Okay, so how?
groups. Yeah,
Okay, so how would blinding help eliminate this procedure bias?
If there's a blending, then neither the observation, all the all the these observers, they do not know the exposure status of the patient. They do not know what patient were receiving what kind of therapy, whether they were receiving the placebo or whether they were receiving the original therapy. So the same treatment could be given to both the group A as well as the group B, right? And if the same treatment is given to both the groups, that means you can easily eliminate the effect of these massages or this physiotherapy easily. And the only effect that would be remaining is the effect of drug, right? That's why blending works for both of these. Because
I don't get
because
it.
this, see, the procedure bias can only be created once you know the exposure status of the patient. You know that the group A was receiving the therapy, so you only give the special treatment to group A. But if you do not know the exposure status of the groups, whether the group A or group B receives the therapy, if you do not know this, then how you will give the special treatment to any group, right? Special treatment can only be given when the exposure status is known.
So nobody's
Yeah.
get,
Yeah.
so nobody knows who is getting what. So nobody can
Exactly.
change the behavior.
Exactly. Nobody can change the behavior. Nobody can manipulate these effects, these results, right? Either both the group will receive the treatment. Either both the group will receive the special treatment, or no group will receive the special treatment at all, right? But if you know the if you know the status of the patient that the group A is receiving a therapy, then you will give only the special treatment to group A, not the group B. So that's how it can create a bias, right?
So wouldn't it be like randomization? Like you are giving special treatment to one group and no special treatment to the other group. So blinding is like the observer and the patient don't know what they are getting, right?
Yeah,
So
exactly.
so if we are talking like procedure bias is you're giving special treatment to a group. So it won't be like you don't give anything to any group, and that is called randomization. No, like
You
random
won't
assignment of either
randomize
treatment or
no,
special treatment
yeah,
towards the
yeah, exactly. This is randomization. You're confusing randomization with the observation, I think.
No, I'm not getting how the blinding will eliminate the procedure bias.
See, if you can only do the procedure bias if you know the status of the patient, right? If you know that the group A is receiving the therapy and group B is not receiving therapy, you know the status of the both group and group B, and then you
Okay.
give the special treatment to group A only. But if you do not know the status of group A or group B at all, then how you will give the special treatment to either of the group? Can you?
No.
So how will you get the procedure bias if you do not get the exposure status of the patient? That's why the blending can reduce the bias, because if the blending was there, if you do not aware of the exposure status of any of the group, then either you have to give the special treatment to both the groups, or you won't give that this special treatment to any of the group, right? So a similar conditions will be created for both the groups, right? That's why that's the thing you ultimately want, a similar conditions for both the groups, and that can be
Okay.
happened by the masking, right? If you get any further doubt, you can write me down the WhatsApp. I will tell you, okay, after a session.
Okay. Okay.
Okay, and yeah, so that's about the this placebo effect and the binding and this blinding. Okay. Okay, so any doubts so far?
Uh, uh, you said
No.
the placebo effect. Placebo
Yeah.
effect is same like Hawthorne effect. Like there also participants are
Yeah,
changing their
exactly.
behavior.
Yeah, exactly. It is a kind of this Hawthorne effect.
Then you said like for the in that like we are using placebo effect to reduce it, right?
I'm using the placebo effect not to reduce the measurement bias, but to reduce the observer expectancy bias.
No, in the that measurement bias that this treatment, I mean the whatever the precaution, there also they say that use placebo group.
Yeah, exactly. See, what gonna happen ultimately if you do not give the placebo, then because of the behavioral differences between the two groups, it will look like the drug is actually working, but it was not the drug, it was the behavior of the patient. Okay, but if you give the drug to both the groups, But in the second group, you're actually using the placebo instead of the drug. But the but the patient was unaware of it. Okay, he know that he's getting some kind of a therapy. So both the groups are drug, the group A and the group B, they both receive the therapy. They both change their behavior, right? So both things are happening in both the groups. And if the conditions are same, see, ultimately you want the similar conditions between both the groups, right? And that's the only way to get a better result. So to create a similar conditions, you need to use a placebo so that this Hawthorne effect could be eliminated. Behavioral changes would be there, but it is equal in both the groups, not one-sided. Whenever the effects are one-sided only, then only you can get the bias. Bias is itself mean one-sided, right?
Yeah.
You want to eliminate this thing. So you want to create conditions similar to both the groups ultimately. So either give the drug to both, either give the similar conditions to both, either remove any condition from both. Then you can get a good study. Okay.
Okay. Thank you.
Okay. Then the most important concept from the bias, which is not a bias at all. I mean, just give me a second. Just a second, everyone. Okay, I will be right back. Okay, so two things are there. One is the confounding bias, and second is the effect modification. Okay, one thing is this confounding bias, and second is the effect modification. Okay, let us say you want to study esophageal cancer. Okay, and you want to know the role of of this, let's say, having chocolates. Okay, you want to know the association between the chocolates and the esophageal cancer. Okay, now what you're going to do, you have selected the two groups. Okay, one with the history of chocolates and other with the history of no chocolates. Okay, and then you have see which of the individuals has the esophageal cancer and which individuals do not have the esophageal cancer. Okay, and what we have found that in the patients who are eating the chocolates, they have a very high incidence of the esophageal cancer, let's say. Okay, and the individuals who were not eating the chocolates, they have a very low incidence of the esophageal cancer. So now the study is is looking like that this chocolate is responsible for the esophageal cancer. Okay, but further, when you have studied the data, you have found that all the individuals who were eating the chocolates, they were also the smokers. Most of the individuals who were eating the chocolates, they were the smoker also. Okay, so now what happened, it is not because of the chocolate but because of the smoking that are having this esophageal cancer. Okay, but because you fail to eliminate this smoking as a confounder, what you are getting is the bias of the result, and the study is making look like this chocolate is the cause of esophageal cancer. You understanding it this much?
Yes.
Yes.
Okay, now how you can eliminate it? Now further, when you divided the data on the basis of the smoking history, okay, so you look in the chocolate group, okay, and you have decided how much are the smokers, how much are the non-smokers. Okay, let's say there was a cohort of the patient. Let me annotate it. There was a cohort of the patient. Okay, and you have selected them on the basis of the chocolates. How much are eating the chocolates? How much of them are not eating the chocolates? Right? This thing. Okay, you have found that all the individuals who are having the chocolates, they have a very high rate of esophageal cancer. Okay, and some of them are the non-esophageal cancer also, without the esophageal cancer, right? Similarly, in the non-chocolates group, there are the individuals who are having the esophageal cancer, who got the esophageal cancer, and then there are some individuals who do not get the esophageal cancer, right? And the rate of the esophageal cancer is very much high in case of the group who were having the chocolates. while the rate of esophageal cancer is very much low, like 1 or 2 individuals out of 100. Okay, in case of those individuals who were not eating the chocolates, but in case of individuals who were eating the chocolates, the case of esophageal cancer was like 50 or 60. So the study is looking, looking at the result of the study, it is look like the chocolate is the cause of esophageal cancer. But when you further stratified the data, when you further look deep into the data, you have analyzed, you have seen that this chocolate eating group is also a smoking group. Most of the individuals in this group are also smokers. Then you further decided to, then you further would decided to, would to to stratify this data, okay, on the basis of the smoking status. You have divided all the group with the chocolates on the basis of smokers and non-smokers. Okay. Similarly, the groups without chocolate on the basis of smokers and the non-smokers. Okay. And now you have decided to get a data of the esophageal cancer on on this data, the smokers and the non-smokers. And what you have found that along with this smoker, this area and this area, okay, both the groups got the same result, the same esophageal cancer rate. Okay. And the group who do not, who were non-smokers, when you analyze the rate of esophageal cancer, the rate of esophageal cancer was same in both the non-smoking groups. Okay, now instead of comparing the chocolate and the non-chocolate group, what you have decided to compare the smoking groups in both of them and the non-smoking group in both of them. And what you will get, the 10 cases of esophageal cancer in the smoking group and the 10 cases of this esophageal cancer in the non-smoking group. Similarly, the 5 cases of esophageal cancer in the non-smoking group and the 5 cases of esophageal cancer in the non-smoking group in this one. Okay. So ultimately, there was a ratio of 1:1, which means the chocolate is ultimately not the cause of cancer, but the smoking is the cause of cancer. Okay. You understand the scenario?
Could you repeat it one more time, please? I got
Let me
lost in it.
let me annotate it again. Wait. Okay. See, there was a group of 200 individuals you have selected. Okay. You have decided to divide them on the basis of the chocolate habits, whether they eat the chocolate or not, and you want to compare the association of the esophageal cancer with the chocolate. Okay. So there are 100 individuals who eat the chocolate, and 100 or let's say 120 individuals, not 100, it would be very same then. 120 individuals who eat the chocolate and only 80 individuals who do not eat the chocolate, let's say. Okay. Then you got the rate of esophageal cancer in both the groups. Okay. And you will get a hypothetical value, let's say out of these 120 individuals, okay, let's say 60 has the esophageal cancer. Okay. And in this 80 group, okay, I'm taking a hypothetical scenario. Okay, it is not the exact calculation, it is just a hypothetical scenario. It could be a x, y, any number. Let's say in this 80 groups, okay, the the esophageal cancer rate was like let's say 30 or 20 or 30, let's say. Okay. So if you look at this group, what is the risk of having the cancer? It would be 60 upon 120, right? This is a risk. In case of this group, it would be a 30 upon 80. Yeah, the risk of having the cancer. Is it okay?
Yes.
So this will be equals to 0.5. Okay. And this equals to what? 3 by 8 equals to? Please use the calculators. Tell me. 0.3 around, right? See, now you can see that the rate of having a cancer in the chocolate eating group is 0.5, while in case of a non-chocolate eating group, it is 0.3. So the study is looking like that a chocolate is a cause of this esophageal cancer. Okay, but now you have decided to stratify this data on the basis of the on the basis of the smoking status. Okay, and what I got out of the 120 individuals, 100 individuals were actually the smokers. Okay, and rest 20 individuals are non-smokers. And similarly, in this group, this 80 group, most of the individuals are non-smokers. Let's say around how many? 60. Let's say 60 of them are the non-smokers, and 20 of them are the smokers. Okay, and out of these 100 individuals, let's say just give me a second. Yeah, out of these 100 individuals, let's say the 50 got the cancer, and out of these 20 individuals, only 10 got the cancer. Okay, similarly, out of these 60 individuals who do not get the cancer, let's say it was just the 20 individuals who got the cancer without the smoking, while out of these 20 individuals, the 10 got the cancer. Okay, you're understanding this much now? These are the non-smokers. Sorry, these are the smokers, and these are the non-smokers. These are the non-smokers, and these are the smokers. Okay. So if you look at the ratio, you can easily show, you can easily say that out of 100 individuals, 50 got the cancer, and out of the 20 individuals, 10 got the cancer. What is the ratio? 1:1. Am I okay?
Yes.
Okay. So the ratio is 1:1, which is, that means the risk of having the cancer is same, as you can see here. Similarly, in case of a non-smokers, the ratio is like 1/2, and you can change it like 40 instead of 30. Let's say it is a 40. Okay, not 30, it is 40, and this is a 30. Okay, so what is the risk of having the cancer? This will be equals to 1/2, right? So 1/2 ratio 1/2, how much is it? 1:1, right? So when you stratified the data on the basis of the smoking, you have found that there is no difference in both the groups. But when you are just looking at the this with chocolate thing, you have seen that this this data makes it look like that that the chocolate is the cause of cancer, but ultimately it was the smoking, not the chocolate. As you can see here, in both the groups who were eating the chocolates, the risk is same in the smokers and in the non-smokers. All the smokers who were eating the chocolate, and these were the smokers who were not eating the chocolate, the risk is same. Similarly, all the non-smokers who were eating the chocolate and all the non-smokers who were not eating the chocolate, the risk is same, as you can see. So so the chocolate is not linked to the esophageal cancer, but it was the smoking, and the smoking was the confounder, which we have neglected. Now you understand the concept of confounder.
Yes, thank you.
Okay, so this is the confounder. A confounder is basically a risk factor which were kind of eliminated or forget to include in our study. Okay, and how we can reduce the confounding? It is by the stratifications. Once we stratify the data on the basis of that confounder, like in this case, the smoking, if you got the result same 1:1 or 1:1 ratio, or no increase in the risk factor in both the groups, then means it must be the confounder. Okay, and second scenario could be like in the same way, let's say let me again just draw this for you. Let's again say that this chocolate group, they have an increased risk of cancer. Okay, and similarly in the non chocolate group, they do not have any increased risk of the cancer. right? And I've decided that the chocolate is a cause of cancer. Okay. But when I stratified the data on the basis of the smoking, what I have got that in case of the smoking groups, okay, in case of the, just a second, I'm misconfusing it somewhere. Just give me a second, guys. Yeah, see, what's going to happen when you stratify the data on the basis of the smoking and the non-smoking. Similarly, in case of this, the smoking and the non-smokings. And now when you are comparing that all the individuals who are smokers, okay, as well as they're eating the chocolates, they have a more rate of esophageal cancer, let's say. They have a more rate of esophageal cancer than those individuals who were non-chocolate eaters but the smokers. Okay, they have a very less rate of esophageal cancer. Similarly, the individuals who were eating the chocolates but they are non-smokers, or in this group who were not eating the chocolate as well as they are non-smokers, they do not have any increased risk of cancer at all. You understanding what I'm trying to say? You first has the group, okay, and you divide the group on the basis of the chocolate habits, okay, and what result you got that in the group who were eating the chocolates, they were having more cases of the esophageal cancer, and have decided that the chocolate is a cause of esophageal cancer. But when I stratified the data on the basis of the smoking and the non-smoking status, what I have found that all the individuals who are chocolate eaters as well as the smokers, they have a very increased risk of smoking. Okay, and the individuals a very high rate of increase, a very high rate of this cancer, right? And while the individuals who were non-chocolate eaters but the smokers, they have a moderate increase in the risk of the esophageal cancer. While the individuals who do not eat the chocolate and they also do not smokes, they have no risk of esophageal cancer. Similarly, all the individuals who eat the chocolate as well as they are non-smokers, they again do not have any risk of esophageal cancer. So now what I can say that in the presence of chocolate as well as the smoking, I'm getting a high rate of esophageal cancer, right? I can say that in the presence of chocolate as well as the smoking, I'm getting a high rate of esophageal cancer. Okay. While when the smoking is not present, even though the chocolate is present, I'm getting a same rate of esophageal cancer or no rate at all. So now I can say that this chocolate is a effect modifier. Can I say that? Or sorry, or the smoking is a effect modifier of this chocolate, not a chocolate, but the smoking is the effect modifier. Can we say that? Because in the presence of smoking only, along with the chocolate, you are having a very high rate of esophageal cancer. So I can say that this smoking is actually a effect modifier of this chocolate. Can I say that? Please respond. I will repeat this fact again. Don't worry if you're having any doubt, because it's very crucial to understand the difference between the confounding and the effect modification. Okay. You want me to repeat again?
No, I think it's okay. You can move forward.
I can write it on my notebook if you want, because it is kind of very
I
difficult
think
to
I
write it
got
on.
it.
Okay.
I think I got
So
it.
please know the difference between the effect modification and the confounding. If you are having an increased risk, see, in both the smoking groups, you are having an increased rate of smoking in the chocolate eating group. Okay. But in the non-smoking groups at all, whether they're eating a chocolate or not, you are having the same rate. So you can easily say that the smoking is the effect modifier of the chocolate. While in the previous example, I can easily say that the smoking is a confounder, because it is ultimately dependent upon the smoking, whether I'm getting the cancer or not. Right? So this is a difference between the confounding and the effect modification. You always need to do the stratification. And in between the same group, if you get the increased rate, that means it is a effect modifier. And in the same groups, if you are having the same rate, that means it is a confounder. Okay, so how you can decrease the confounding? Well, the first thing is by the repeated studies. You have to perform the single study over a multiple times. Okay, so after the multiple period of time, you can get some results, you can compare the results, and then you can move forward. So multiple studies, same as like increasing the sample size. If you increase the sample size, then you can get a better precision, right? Like I told you, you will get a better power. So multiple studies could be there. The crossover studies, because in case of a crossover studies, you are kind of comparing the subjects with their own cells, right? So crossover studies can reduce the confounding. And third is the most important thing, which is the matching. If you match the patients on the basis of the smoking history and the age, the sex, the height, the weight, okay, the skin color, or the hereditary conditions, if you match the two groups with the exact same with the demographic factors, then you can decrease the confounding. Because this way you can be damn well sure that the both the groups are having the same thing, not the some kind of a bias would be there, right? So matching is always reduce the confounding bias, very important. And the third most important thing is the randomization. If you randomly distribute the two groups in either of the group, that with the individuals in either of the two groups randomly, which is the case in the randomized clinical trials, you can reduce the confounding. Okay, so which is the best study to reduce the confounding? It would be the randomized clinical trials. The RCTs are the best study to reduce the confounding bias. Most important thing. So matching, multiplied studies, crossover studies, and the randomization, they will always reduce the confounding bias. Okay, any doubt in the confounding bias?
No.
Okay, then comes the lag time bias and the length time bias. Okay, see, let us suppose there is a cancer. Okay, and the usual way to detect the cancer is at the 50 years of age. Okay, you start the disease process at the early 30s. Let's say the patient got a cancer at 30 years of the age. Okay, and by the conventional method, I am detecting the cancer at a 50 years of age. Okay, now I have made a test which can easily detect the cancer at the age of like say 40 years. Okay, and let's say the death of the patient occurs at 70. Note the data. The disease process started at 30. I'm detecting the cancer at the age of 50, and the death is occurring at the age of 70. Okay, so what is the initial survival time between the detection of the cancer and the death? It would be 20 years, right? 50, 70 minus 50, it would be 20 years. Are you getting me?
Yes.
Okay, now what happens? I have made a test which can detect the cancer at the age of 40. Okay, and if I compare my survival time now, it will make look like, because 70 minus 40 is 30. It is making look like that because of this new test, the survival time of the cancer is increased. Because the initial survival time after the detection of the cancer was 20 years only, but after this test, the survival time is now 30 years. So the test is making look like that because of the test, the survival time is actually increased. But you already know that the death is actually happening at the 70 years only, which is the same time. And this is known as a lead time bias, when the early detection is confused with the increased survival. So the early detection of a disease making it look like that the survival time of my disease is increased because of this new test. But in actual, the death is happening in the same way, right? The early detection making seem like the survival has increased, but the disease nature and history has not been changed. It was always the same. The death is occurring at the age of 70 only. Okay, so this is known as the lead time bias. Any doubt in it?
No.
No.
Now let us see. Then comes the length time bias. Now let's say there is a disease which has two of variants. One is the rapid fatality, and next is the very slow or the progressive rate, very slow rate. Okay, a cancer who has a two type of variants. One is a very rapid fatal, and second type is a very slow progressing type. Okay, you have discovered a test, and let us say there is a individuals, and just give me a second to create an example for you. Okay, see, so, and let's say most of the deaths from the rapid cases were occurring before 50 years of age. Okay, and you have made a test, okay, which will detect the disease process at the age of 50. You run the test at the 50 years old patients, all the 50 years old patient, to detect the presence of cancer. Now, all the individuals which have a very rapid course, okay, which have the variants of the cancer, which is rapidly fatal, they will die even before the detection, right? And only few cases of these patients will be detected, while all the patients who are having a very long or very slow nature of the disease of this cancer, they will be more likely to detect by this test. Am I right? Are you getting me?
Yes.
Okay, so test makes it look like that all those individuals which were diagnosed by this test, they have a very long survival than those individuals who were not were diagnosed with the test, right? All the individuals which were diagnosed with the test, they have a longer survival than all the individuals which were not were diagnosed with the test. So it makes look like the test is actually very beneficial, or the test is actually increasing the survival rate of the patient. But in actually it is not true. Why? Because disease has two processes. One is a rapid fatal, and second is a very slow progressing. And only the slowly progressing cases will be detected by the test. Okay. So the screening test will detect a disease process with a long latency period, while those with the shorter latency period, they will become symptomatic earlier and die earlier than those who will become symptomatic late. So a slowly progressive cancer is most likely to be detected by a screening test than a rapidly progressive cancer. The rapid one will die first, and the slow ones will die later, and the test will detect the slow ones. So it will make look like the test is actually increasing the survival rate of these patients, but it is not true at all. Okay, so this is the length time biased.
So what is the difference between the two, lead time bias and length time bias?
In case of a
Both
lead
are
time bias,
related.
in case of a lag time bias, you're actually kind of early detecting the cancer or the disease process. Okay, while in case of a land time bias, you're only detecting those cases who are slowly progressive, not the early ones, but only those cases which are slowly and progressive. Okay, although both of these things look like the same, in both the cases you are actually getting an increased survival rate, but in this case only those patients who have a second variance of the cancer, they will have an increased survival rate. Okay, but in case of a lag time bias, because you're just early detecting the disease, it will make look like that the disease has an increased survival rate because of this test, right? For the lag time bias, the disease must be of two variants. One is the rapid fatality type, and second is the slowly progressive. While in case of a lag time bias, the disease must be having a one type of variance only. Okay.
Would you quote another example for length time bias?
Uh, Actually, this is the only example where you encounter lag time bias. A cancer which has a very rapid fatality rate. Okay, let us suppose see there is a timeline of the patients. Okay, and for a cancer, the two variants are exist. Okay, you can turn off your mic.
I was
My
gonna
voice
say
is echoing
something.
here. Yeah.
I was gonna say something where I read in long-term bias, you can use GBM, glioblastoma, because before you detect it, you have like 6 to 10, 6 months to a year.
Yeah, exactly.
Yeah, for that. And the lead time bias could be, follicular carcinoma, where
That's
you
what I'm
have
saying.
like, yeah.
In case of a lag time bias, you need to have a cancer or a disease which has two variance types. One variance is a rapidly fatal variance, and second variance is a very slowly progressive variance. But in case of a lag time bias, you need to only have a one type of variance of a cancer, so that you will detect the disease process early and it will make look like that the survival is increased. But in case of a length time bias, because the two variants exist, the rapid fatal variance can never be detected by by this test, but only the slowly progressive variance will be detected by the test. And it will make look like that all the cases, all the slowly progressive cases which were detected by the test are actually having a very high survival rate. So ultimately the test increased the survival rate, it will shows, right? But in actual practice, it was not true. It was just a disease process which are very slowly progressive. But you fail to encounter that fact. Okay, that's why you get the length time bias, and in this case, you will get the lag time bias. If you want, I can make a separate slide on both of these things for tomorrow's class, if you want. Okay, for a better and a clear understanding, if you want. Okay.
Okay, sir.
Okay.
Okay.
Any doubt for so far on this lag time, length time, other than this one?
No.
No.
Okay. So now you know already the confounding bias and the effect modification. Confounding bias occurs when the stratification, after the stratification, you got the similar 1:1 ratio. Okay, but in case of effect modification, when all the groups which have both the exposure will got an increased rate of a certain cancer or certain disease, okay, then you got the effect modification. For the lag time bias, you are increasing the survival rate. It is seem like the survival rate is increased by the early detection of the disease. In case of a length time bias, it seems like the survival rate is increased because of the detection of only the slowly progressive variants of the cancer or the disease process. Okay. Then comes the accumulation effect. Okay, a certain smoking, let's say, it will always gonna cause of the it will always gonna cause the lung cancer after, let's say, 5 years. So all the individuals who smoke the cigarette for more than 5 years, they will get the cancer. They will get the increased risk of cancer than those individuals who were smoking for less than 5 years, let's say. Okay, so step one will ask you why the smokers who are smoking for more than 5 years, why only they will get the cancer, but not the smokers who were smoking for less than 5 years? This would be the accumulation effect. Okay, when the exposure or the risk to a certain disease can be explained by the duration of the exposure. Okay, so you get the disease or the benefit only after consuming the exposure after a certain period of time. Before that period of time, you won't get any effect. And this is because of the accumulation effect. It's like, accumulating these carcinogens in your body. All the carcinogens you will keep on accumulating, and after 5 years, when a certain quantity is reached, when a certain concentration is reached, you will get the lung cancer. Similar true for the vitamins. You have to take the vitamins for a certain period of time before you can have any effect in your body. And why? Because of the accumulation, the concentration of these vitamins will be increase. That effect will be increased as the concentration increase, and after a certain period of time, when the concentration reaches a certain maximum limit, you will get the effect. So this is the accumulation effect. Okay. Any doubt in it?
No.
Okay, so we have done with this page completely. Okay, just a second. Yeah. Okay, then comes the measurement of the standard tendency. One is the mean, second is the median, and third is the most. Mean is basically the sum of all the values divided by total number of values. Okay. Median is basically the middle value of the list. Let us suppose you have a data of like 1, 2, 8, 7, 6, 5, 4, as a, from 1 to 10. Let us suppose, let me show you. You have a data for 1, 2, 5, 8, 10. Okay, then 9, then 6, let's say, in this order. Okay, and if the step one will ask you to calculate the median, then first you need to arrange this data in the order of increasing number, which means 1, 2, okay, then comes the 5. Okay, then comes the 6, then comes the 8, then comes the 9, and then comes the 10. Okay, then you need to choose the middle value. And what is the middle value of all these values? 1, 2, 3, 4, 5, 6, 7 values we have, and the middle value must be this 6. So the median of this data is the 6. Okay, so first of all, you have to sort the data on the basis of the increasing size of the quantity. Okay, then you need to choose the middle value. In case if it is because as you can see there are 7 numbers present, which means it is a odd data. If you get an even data, let us say you will get you also get after 6 you also get a 4 here. So you need to include 4 before 5. So 1, 2, 4, 5, 6, 8, 9, 10 you will get. Now what's gonna happen, you will get two values, two middle values, which is 5 and 6. These are the middle values, 3 values here and 3 values here, right? So 5 and 6 are the middle values. So what is the median? Median will be the middle value of these two values, which is the 5.5, or the mean of these two values. Okay, this is the median. Okay, so first you need to arrange the data in the ascending sequence, and then you need to choose the middle value. Okay, and then finally comes the mode. The most common value in a certain data is known as the mode. Okay, and if the step 1 asks you that which of these value actually affected by the outliers, for let's say there is a certain data in which 70 values are 10. Okay, 10 repeated 70 times, 6 repeated 9 repeated, let's say 12 times, and 8 repeated like say 10 times. Then you suddenly got a value of kind of 1. Okay, a complete outlier. So guys, tell me, does it affect the mode of the data? What will be the mode? You have this. Let me annotate it again for you. Let's say you have 10 values, and this 10 value repeated for 90 times or 70 times, let's say. Like 10, 10, 10, 10, 10, 10 for the 70 times. Okay. You have a value number 9, which is repeated for like, let's say 20 times. Okay. You have another value, which is 8, and it is repeated for kind of 10 times. Okay. You have these three values in the data, 10, 9, and 8. Okay. For a certain enzyme level or something like that. Okay. Then suddenly you get a data of 6, which is outlier completely to these values, right? So tell me, does it gonna affect my mode at all? What would be my mode in this data?
Your mode would be 10.
Mode would be 10, right? It will remain same because it is 70 times repeated, highest times. So as you can see here, because my mode is least affected by the outliers, this is it. Okay. So mode is the most common value, and this is the value which is least affected by the outliers. Okay. And mean is the value which is most affected by the outliers. Whenever an extreme value is there, okay, the most commonly affected value is your mean. Okay, and most is for the least. Okay, then comes the measurement of the dispersion. One is the standard deviation. Okay, and second is the standard error. For the standard deviation, you can see that. Let us suppose there is a data. Let me create a data for you. This is a graph, and you get a certain level of an enzyme, let's say. Okay, for the myocardial infarction, and the highest value was correspond to 100. Okay, and let's say this 100 value of the enzyme came in like kind of 90 patients. 90 patients got the value of 100 for a certain enzyme. Then comes the value which is 90. Okay, and this value is present in only 50 patients, let's say. Okay, then comes a value again which is 80, and this 80 value is present in only 25 patients. So what would be my standard deviation? this would be this 10. The difference in the different values. Okay, the difference in the different values known as the standard deviation. Okay, this is the standard deviation. Okay, and yeah, so for that you always need to create a mean first. Okay, and the mean value. Okay, all the values, how much they differ from the mean values, the set of values which are different from the mean values. This is the standard deviation. And then comes the standard error. To calculate the standard error, you will do just one thing, which is do the standard error divided by the under root of all number of values. And is a sample size or the number of values you have. Okay, so standard deviation divided by the under root of sample size or the number of values you have. This is the standard error. Okay, so for the standard error, what you will do, let's say you want to would do a study on this population. Okay, and this population has like 1,000 individuals in it. Okay, but doing a study on this much big population is kind of very difficult, right? So what you do, you will extract out the 100 individuals from this population which represent this sample data. Okay, instead of taking 1,000 patients, you just extracted out 100 individuals which represent this population, and you do your study on these 100 patients. And after doing the study on these 100 patients, the data you gather, okay, you will use the data to represent this 1,000 individual population. Okay, the data you gather from the 100 patient population, you will apply this data to this population of the 1,000, and that's where you need to use the standard error. So the data that you gathered from the 100 population, this would be your standard error. Okay, and the standard deviation is from this 1,000 population. You understand this? So how the values from this smaller data is differ from this big data, this would be your standard error. Okay, so it estimates how much the variability exists in a theoretical set of sample, that means around the true mean population. Okay, how much the mean, which is from this 100 population, is differ from the mean of this 1,000 population. This would be my standard error. The difference between the standard error of these two populations. Okay, understand this now?
Yes.
For example, if we take a small sample and use its characteristics on a large population, example for a 10 BP ratings, and take the mean of that and hope that this mean represent the BP of 10,000 people, then you will get a standard error. Okay, so it basically tells you that how precisely you know the true mean. If the standard error is very much less, that means that means you know the mean of the true population very well. Okay, so the low is the standard error. Okay, the closer you are to the mean of the real population, the lower is your standard error, which means you are very much closer to the true mean of the population. Okay, it's just a difference between the means of your sample size and the true population. Then comes a normal distribution, and in the normal distribution, the mean will always be equals to mode, which will be equals to the median. Very much important. In a normal Gaussian population, you will get the mean, mode, and median at this point already. Okay, and for going one standard deviation here to here, you will cover almost 68% of the population. For moving two standard deviation, you will cover almost 95% of the population. For moving three standard deviation back and forth, you will cover almost 99.7% of the population. Okay, so step one will give you a data of like a score of the individual or the students. Okay, like 90%, then 80%, then the 70%, and they will ask you how much of the individuals can get a score of 50% only. Okay, so for that you need to know where the 50% actually lies, whether it is a 1 standard deviation, 2 standard deviation, or 3 standard deviation. So they will give you a mean of the study or the class, and they will tell you the mean is 90. or let us say the mean is not 90, but the mean is kind of 60 for say. The mean is 60. Okay, then you have the 70, you have the 80 here, you have the 90 here, and you have the 100 here. Okay, similarly, you have the 50 here, 60, 50, 40 here, 30 here, 20 here, and 10 here. Okay, so the range of the individual between the score of this 50 to 70, it will cover almost 68% of the individuals. So 60% of the classmates, 68% of the classmates, they will get a score between the 50 and the 70. Okay, then 95% of the classmates, they will get a score between the 40 and the 80. This is for the 80, this is for the 40. Okay, and the 99.7% of the classmates, they will get a score between the 30 and the 90. Okay, 99.7. So step 1 will ask you what are the chances or what is the percentage of the individuals that will get a score of 100%. So because you know that 99.7% already cover in this part, in this 3 to 9, okay, if you take the further more than 0.3%, you will go here, and 0.3% you will go here, right? So 0.15% will move here, and 0.515% will move here. So only 0.515% will get a score of 100. You understand this?
Yes.
Okay, so you always have to, the remaining 0.3, you have to divide it in the further part and the before part all. Okay, in both the parts you have to divide it equally, like 0.3, the half of 0.3 will be 0.15, 0.15. So 0.15% of the people of the students will get a score of 100, and 0.15% of the student will get a score of 20% only. So do not get confused. Okay, they will ask you about these outliers, how much individuals can get a score of this much and how much individuals will get a score of this much. So you can easily identify this data. Just you need a presence of your mind. Then comes the non-normal distributions, in which you have a tail either on the side. Okay, in case of a positively skewed, you will have a mean at the highest side, then comes the median, and then comes the mode. Okay, in case of a negative skewed distribution, you will have a mean, which is the smallest one, then the median, and then the mode is the largest of the term. Okay, so in case of a positively skewed distribution, the mean is highest, then comes median, then comes mode. Okay, and the tail part, which is this part, it is always on the right side. Okay, in case of a negatively skewed distribution, the mean is the smallest one, then comes the median, and mode is the largest one, and the tail is always on the left side. So you can easily see that the mean is always towards the tail, and the mode is always towards the highest value, highest number of individual value. Okay, mean is always towards the tail. So step 1 will just ask you this, that what could be the mean of this graph, okay, which is the highest value in this graph, which could be the smallest value in the graph. Okay, very easy. They can also ask you whether this distribution is a positively skewed one or the negatively skewed one. Okay, no complex question can be made on this part. Okay, very much important. No complex question can be made on this part. Any doubts so far?
No.
Okay, then we will take a short break of 10 minutes and then start again from the statistical hypothesis. Okay.
Thank you.
If someone has any doubt, he can write me on the WhatsApp. I will reply them after the session. Okay. Okay, so I finished with the statistical distributions. We have discussed the standard deviation, which is the mean, and all the values which are differ from the mean. It is known as the standard deviation. How much the variabilities are found in the different means. Okay, we have discussed the standard error. In the standard error, you take a smaller population, a smaller sample size, and then you want to fit that smaller sample size into a very large population. And then the difference between the mean on this large population and mean on this smaller sample size is known as the standard error. If the standard error is low, that means you know the mean very much with with a very high precision. We have discussed the mean, mode, and median. We have discussed how to calculate the mean, mode, and median. We have discussed the positively skewed distribution and the negatively skewed distribution. And now we're going to discuss the hypotheses. In the hypothesis, what's going to happen? You have two values. One is the null hypothesis, and second is the alternate hypothesis. Whenever you did a study, okay, you have prepared a data, okay, and now you are going to analyze the data, whether your study is true for the data or not. Okay, you want to analyze the data, and after the analyzing the data, your study have found that there is no actual difference exist in the study. Okay, that means it is a null hypothesis, which means there is no difference or relationship exist between the risk and the outcome. Okay, you have made a study, you have collected the data, and after the collection of the data, when you're going to analyze the study between the risk factor and the association, if you have found that there is a no difference or relationship exist between the risk factor and the outcome, that means it is a null hypothesis. If your study have found that that there is a difference or a relationship exists between the risk factor and the association, sorry, between the risk factor and the outcome, then that means it is a alternative hypothesis or the H1. Okay, and the probability of the hypothesis totally depend upon the difference of the mean. Okay, if the mean between the normal patient and the and this diseased patient is very much few. For example, let's say you want to detect the let's say you have made a test which detect a troponin level in the myocardial infarction patient, or any enzyme, not the troponin, any enzyme level in the myocardial infarction patient and the non-MI patient, and you have found that the mean of the non-MI patient of this enzyme is 100, and the mean who's this? Okay, and the mean where were we? We were discussing about the sorry. So you have made a test who will detect a certain enzyme level in the MI patient and the non-MI patient. Okay, and the mean value in the MI patient is 100 of this enzyme. Okay, and the mean value in the non-MI patient is, let's say, 98 or 99. So as you can see, the difference of the mean is very much less between the two. Okay, so this will decrease the chances of being it an alternative hypothesis, which means the null hypothesis could be true. But if the difference is more, okay, let's say the 100 in the MI and 70 or 60 in the non-MI, that means it will give the the study a very high power of the hypothesis. Okay, so the probability of the hypothesis depend upon the difference between the mean. If the mean is more, then the chances of being it a H1 is more. Okay, if the distance of the mean is less, that means the chances of accepting the null hypothesis is very much high, right? Second one is the scattering of the data. If the data is very much scattered between the two groups and the data is often being overlapping, then the and then chances of the study being a alternative study is very much less. Okay, and the chances of accepting the null hypothesis is very much high. For example, if the data is something like that, this is one group, the non-diseased group. Okay, and this is the diseased group. As you can see, the overlapping of the data between the two group is very much high. Okay, so the chances of it being a null hypothesis or rejecting the studies are very much high again. Okay, and if the scattering of the data is very much low and the overlapping of the data is very much low, then the chances of accepting the study is very much high again, right? And of course, the number of subject tested. If the sample size is increased, then the chances of accepting the study would be increased. The power of the study would be increased. And that is the only thing that you can do to make a study look better. Okay, because the difference in the mean is gonna be same for both for this enzyme. You cannot change that. Okay, the scattering of the data gonna be remain same. You cannot change that. But what is the only thing that you can change in a study? That would be the number of subject tested. Okay, if you increase your sample size, then by increasing the sample size, you are increasing your chances of the study being a H1, okay, being accepted. Okay, you understand this? The three variables. Yeah.
Yes.
Please respond.
Yes,
Okay, got it
yes,
now.
yes.
So whenever the step one will ask you what could increase the power of the study, what can give it a more good chances to being a H1, it would be to increase the sample size, because that is the only thing that you can do for your study. Okay, let me clear this. Now then come all the chances or the outcomes of the statistical hypothesis testing. Okay, that is, suppose you have performed a study and you have analyzed it. Okay, and based on your analysis, you have given either the H0 or the H1, which means your study rejects the H0, which means accepting the H1. Okay, it would be a case of the H1. Okay, and after analyzing the data, what you have found that your study does not reject the H2, means accepting the H2. Okay, in this scenario, your studies passed. In this scenario, your studies failed. Okay, something like that. But in reality, this is the H1 and this is the H0. Okay, so four things can be happen, or three things only. Okay, one is that in the real life, the difference is actually existing, the relationship is actually existing, and when you analyzed your data, you have found the same thing, that yeah, the relationship is existing. Then you can call it a power, or it is known as a 1 minus beta. Okay, but second scenario, what happened in the real life, there was no difference or no relationship existed in your study in the reality, but somehow you find the relationship. Okay, after analyzing the data, you have found the relationship because of some biased thing or something like that, because some kind of an error. Okay, but in the real life, the difference wasn't there. Okay, you call it a type 1 error or the alpha error. Okay, third scenario, that in real life the relationship was existed. Okay, but because of a less sample size or a very less mean or something like that, or any kind of an error, your study just missed it. Okay, after analyzing the data, you have concluded that there is no specific association existed between the risk factor and the association and this outcome. Okay, but in the real life, there was a difference, but your study has missed it. You call it a beta error or the type 2 error. Okay, and 1 minus beta would be your power, because of chances of failing to detect a difference. This would be your type 2 error. And if you remove those chances, you will get the acceptance of the study, which is the power of the study. Okay, and how you can increase the power? By, of course, increasing the sample size. The more number of samples you collected, the more large data you will gather, and as a result, the power of the study would be increased. Okay, a largest difference between the means we have discussed. If the mean difference is larger, then you can easily detect it. Okay, if the mean difference is very much less, then you can kind of miss it. Okay, then the less data scattering, which means a precise measurement. If the measurement is precise, if the scattering of the data is very much less, then you can get a very high power. For both of these things, the larger difference and the less scattering, you cannot do anything for that. Okay, it is dependent on your test completely. But the only thing that you can change in your study is the sample size. Okay, so the only way to increase the power of your study by yourself is to increase the sample size. Most important thing. Okay, that's about these four outcomes. So first is your type 1 error or the alpha error. Okay, it is basically the probability of observing the difference due to a chance only. In reality, there was no difference, but your study somehow by chance gets a difference very falsely. So the probability of observing the difference due to a chance alone, this is known as the type 1 error. Okay, and for a study to be a successful study anytime, the p-value should be less than 5%. Okay, p-value is basically a chance of error. Okay, and this chance of error in your study, it must be less than 5%. Okay, because if the chances of the study is more than 5%, that means your study is incorrect. you have some kind of error in the study. Okay, very important. This p-value must be less than 0.5%, 0.05%. It is very much true. Okay, because these are the chances where you get an error. You get a, these are chances that you are somehow getting the result true, even when the result is actually false. Okay, you want it to be as minimum as possible. So it must be less than 5%. Very much important. Okay. And you, yeah, that's about it. Okay, then comes the type 2 error or the beta error. We have discussed it. It would be a neglecting a difference when in the true life there is one existing. Okay, the probability of concluding that there is no difference when there is one in the reality. This would be your type 2 error. Or how you can reduce a type 2 error? By increasing the sample size, by increase the expected effective size, and by increasing the precision of the measurement. Okay, it is kind of a false negative result. Okay, any doubt in this part?
No.
Okay. Then comes the confidence interval. Okay, see, you have performed a study and you have found a certain mean. Let's say you want to know the diagnosis of the diabetes patient, and you have concluded that that in your study the level of the blood sugar in the diabetes patients for, let's say, 120. Okay, and then you have made a range like 110 to 130, and now you are saying that you are 75%, sorry, you are 95% confident. Then when this study repeated again by other individual, okay, the range of the blood glucose in the diabetes patient will fall in this range, the 110 to 130. This is a confidence interval. Okay, if the other studies repeat the same measurements again, then there are 95% of chances or 99% of chances, depending upon the confidence interval, that the mean will fall in this range only, your given range. For example, if you made a study for the for diabetes, and you want to check the blood glucose level in the patients with the diabetes, and you have concluded that in your study you have got a diabetes level of 120 in the patients, and now you are saying that you are 95% confident that when the same study repeat again, the 95% of chances are there that the range of the blood glucose will fall in 110 to 130. This is the confidence interval. And the formula for the confidence interval will be equals to the mean, okay, plus minus. If it is for the 99, if it is for the 95%, then it would be 1.96 multiplied by standard deviation by n, which is a standard error. So mean plus minus 1.96 is standard error. This is for the 95%. For the 99%, the formula would be mean plus minus 2.58 into standard error. Okay. For the 99%, for the 95%, you must have a p-value less than 0.05, which means the chance of error must be less than 5%. Okay. For a 99% confidence interval limit, the chance of error must be less than 1%. Okay, if the chances of error will be more than 1%, then your study would be rejected. Okay, and as you can see from this formula, whenever you increase the sample size, the n, whenever you increase the sample size, what's going to happen? The value of this term would be decreased, and as a result, the confidence interval would be decreased, right? And when you decrease the sample size, the value of this term would be increased, and as a result, the confidence interval would be increased. As before I was saying, like, I have found that 120 was the mean of the blood glucose in my study. Okay, and now I want to create a confidence interval, and after the formation of confidence interval, I have found that the mean, that the range of this confidence interval was 110 to 130. Now, if I increase my sample size, okay, if I increase my sample size, and what's going to happen? The range would be decreased. Now I can say that whenever someone repeated the study, the 95% of time, there are chances that the mean of their study will fall in the range of 105 to 125. See, my confidence interval is decreased now, 105 to 125. It was originally 110 to 130. So if I increase the sample size, I am decreasing the confidence interval. Okay, this is very important to know. Okay, so step 1 will give you two values, two studies. Okay, and they will ask you whether the study is true or not. Okay, so you need to know if the 95% of confidence interval for a mean difference of two studies or two variables, if it anywhere includes a zero, let us suppose you will get a range for mean of two groups. Okay, you got a confidence interval range of let's say -1 to +1. As you can see, this value is crossing the zero. Okay, and whenever this thing happened, your study immediately accept the H0. Okay, or H0 is not rejected. For example, you want to you want to measure the blood pressure of young age group and the old age groups. Okay, and somehow you're crossing the value of zero in the difference between the blood pressures. Okay, and if you cross the zero, that means the study is not true. That means the H0 is accepted. Null hypothesis is accepted. Okay, in case of a odds ratio or the relative risk, if the odds ratio range or the relative risk range crosses 1, okay, for example, any if you get a relative risk of like 0.6 to 1.3, so this value crosses a 1, and whenever a value crosses a 1, that means H0 is not rejected. Okay, similarly, if you get a graph and the graphs are overlying to each other, okay, then again this means the this study is not accepted. Okay, so if a statistically significant difference is there, okay, but the confidence interval between the two groups is overlapping in the graph, like that like this value and this value you are getting. So you can see that both the graphs are overlapping here. This means the study is rejected. H value is H0 is accepted. Okay. So for the mean 0, for the odds ratio or the relative risk, it would be 1. And for the graph, if there is an overlapping on the graphs, then your study is rejected completely. Okay. And normally, whenever you want to report a study, the 95% confidence interval is reported most commonly. Very much important. Okay, and step 1 will also ask you what gonna happen if you lower down the p-value. For example, let's say initially you want the confidence interval to be 95%. Okay, but now you want the confidence interval to be 99%. Then what gonna happen with your study? Because see, now initially you need the error chances. Let me highlight. Initially you need the error chances to be 5%. As you can see, the alpha would be 5%, right? But now you need the error chances to be less than 1%. That means the chances of finding a significant result is decreased. As you can see here, the chances of finding a significant result is now decreased very much because you need to have a study, less than 1% of error. So that means the rejecting of the study would be increased whenever you increase a confidence interval. Very much important to know. Okay, whenever you decided to lower down the p-value, to lower down the alpha value, you're actually doing what? The chances of finding a statistically significant study is decreasing. Okay, the chances of getting a H1 is decreasing. You understand this?
Yes.
No, repeat.
Okay, see, whenever a step 1 will ask you that there is a certain author or a researcher and they want to lower down their alpha value. What is the alpha value? The chances of being an error, the chances of being the study to be accepted just by an error. Okay, normally you need the alpha value or the p value, I must say, the p value to be less than 0.05 when you set the alpha value for 5. Okay, if you're setting the alpha value for 1%, that means if you get a p value greater than 1%, the chances of error if in the study was 1%, more than 1%, then your study would be rejected. That means the chances of finding a statistically significant result in the study is decreased now, because initially when you need the 5% error, now you need just the 1% error and your study would be rejected. So the chances of finding a statistically significant result in your study is not decreased because of a less margin of error, right? So they will mention you this option, the chances of find, and they will ask you, sorry, what they will give you that, let me show you this. See, as you can see, the confidence level is equals to 1 minus alpha somehow, okay? And if the p-value is decreased, the confidence interval is increased. As you can see, alpha is kind of a p, right? If the p-value is decreased, then the confidence interval would be increased, right? So if you increase your confidence interval, you need to have a very low p-value, right? And if you decrease the p-value, that means the chances of finding a statistically significant result is decreased again, because the narrow, and because this what the margin of the error is very much narrow now, right? If you have the error more than 1%, your study would be rejected completely. So the chances of finding a statistically significant result would be decreased now, because if you increase the confidence interval level. Okay.
Okay. Would you repeat this overlap thing?
Okay. Whenever you did a study and you made a graph of the study, okay, of the values, okay, and if the values will be overlap in two groups, like this value and this value. Okay, these are number of individuals having these values, and these are the number of individuals having this value. Okay, if this value overlies to each other in the graph, that means your H0 is accepted. H0 is a null hypothesis. It is accepted, and you won't get any difference, or which means there is no relationship existed between the study groups. Okay, if you get the overlapping in the graph, you will immediately know once you get the graph in the UL. Don't worry about it. They will ask you whether the study is accepted or not. So you will reject the study if the overlapping is happened. Okay.
So I guess
We
Any
can
other
say we
example?
reject the study or we reject the null hypothesis. Which one? Or both?
Sorry, ask it again.
When they are overlapping, that means that we reject the null hypothesis or you reject the H1?
We will accept the null hypothesis and reject the H1.
Okay.
Okay. And one more thing I want to tell you, once you increase the sample size, you always need to lower down your p-values. Very important. Once you increase the sample size, you always need to lower down the p-values. Can anyone tell me why? It is a very interesting concept.
To get more statistically significant results.
How does it gonna get me more statistically significant result?
Increase size, sample size.
Okay, I'm increasing the sample size, but now I need to decrease the p-value. Why do I need to decrease the p-value?
To reduce error.
And how does it reduce the error? And why do I need to reduce? Because initially, I'm getting only 5% error now. Initially, when my sample size was low, I'm getting the 5% error. And now my sample size is big. I'm still getting the 5% error. Then what's the problem? Why do I need to decrease the p-value? If I'm getting the same percentage, yeah.
To increase the confidence, we need to lower the value?
No. See, let me show you this. Let us suppose initially you have a sample size of 100. Okay. And your p-value was 0.05, which means still you can have an error of 5%. That means out of 100 values, if you have error in the 5 values, then your study could be accepted. Okay. But let us suppose you have increased your sample size to like say 1 to 10,000. From 100 to 10,000, you have increased your sample size. Now, what will happen if you keep the error of 5%? How many errors would you get? 500, right?
500.
See, 500 errors in a study. That's why you need to lower down the p-value to the 0.01 so that you can get only 100 errors. Okay, so whenever the sample size of a study increase, you always need to lower down the p-values margin. Okay. because you have to reject the study if it get 500 errors. As you can see, this is a very big value. Okay, so step 1 will ask you this. Okay, they will give you a scenario of a certain study where they're studying of like 1,000 or 1 lakh or 1 million of a population, and they will tell you that these authors, they have lowered on the p-values. Okay, initially when the sample size was low, the p-value was 0.05. When they have did a meta-analysis, because in the meta-analysis you are actually increased sample size, now you have to lower down the p-value to 0.01. So they will ask you why the p-value is lower down, to decrease the error size, because as you can see, there are 5 errors initially, but now there are kind of 500 errors, so you need to decrease the error numbers, and that's why you need to lower down the p-values. Okay, is it clear?
Yes.
Yes.
Okay, so we can move forward now. That's everything on this page that you need to know.
Hello.
Yeah.
Hello.
Someone.
Yes.
Yeah.
My question here is, in a study, do I really want my confidence interval to be high or to be low?
It totally depends on you. If you think your study is kind of very high type, a very precise type, and the margin of error is very much low, you can give a 99% also. It's totally up to you. If you're very confident in your study that, yeah, my study is great and it has a very narrow margin of error, then you can use the p-value 0.01 and you can give a very high this confidence interval limit, because 99% of CI means that 99% times whenever someone repeats your study, the chances are their mean value will fall in your given range. The range you have given to the data analyzers, 99% times whenever someone repeats your study again, their mean will fall in that same range. Okay, so it's just that most of the time 95% is given. Sometimes they also give you 99%. The most commonly used value is a 95% confidence interval. Okay, okay,
Thank you.
Yes. Thank you.
okay. So yeah, I think that's all about a confidence interval. One more thing I want to ask you. See, like I told you in the positive predicted value and the negative predicted value, that what are the chances that once I got a positive result, then my result is actually positive. It is known as the positive predicted value, right? Agree?
Yes. Yes.
So if I ask you that what are the chances when I got a positive result, I'm actually negative. I already know that what are the chances of being actually positive when I got a positive result. Now I want to know what are the chances to being actually negative when I got a positive result. Understanding my question?
Yes.
Anyone?
No. Please repeat the question.
Repeat the question.
See, what does the PPV means? The positive predicted value. It means that the chances that once I got a positive result, then I'm actually positive for the disease. Agree?
Yes.
Now I'm asking you, I have got a result positive. Now, what are the chances that I'm actually negative? I already know the PP value. Examiner has given me the PP value. Now the examiner is asking me that what are the chances of this patient being actually negative when the test is positive.
Is it false negative or?
Yeah, kind of false positive chances. Chances of being a false positive.
False positive.
When the PPV is given.
Mhm.
It's very, very, very simple, very easy. The chances of being not actually positive, simple. The chances of being actually negative is equals to the chances of being actually not positive, right? Can I say that? I want to know that my test is positive. See, in both the scenarios, when the test is actually positive, oh, sorry, the two scenarios can be existed with the positive predictive value. I've run the test, I've got the positive. Now, if I say that what are the chances that I'm actually positive, then it is a positive predicted value. Okay. But now when I get positive and I want to know what are the chances that I'm actually negative, not the positive. So can I say that these chances are equal to those chances when I'm actually not positive? The chance of being negative is actually not being positive, right?
Yeah.
So can I say that 1 minus PPV?
Yes.
1 minus or 100% minus those chances in which I'm actually positive, right?
Yes.
So the chance of actually being a negative despite a positive result will be your 1 minus positive predicted value. And similarly, it goes for the negative predicted value. For the negative predicted value, I've got a negative test. What are the chances that I'm actually negative will be your negative predicted value. But what are the chances that I'm actually positive? That will be 1 minus of all the chances when I'm actually negative, which means 1 minus negative predicted value, because both of these are the chances, right? So just you need to do 1 minus of these values, okay? You will get the answer. They will try to trick you into this, but do not get confused, okay?
Repeat it, please.
See, for the positive predicted value, I have mentioned that it is a chances for being actually positive with the disease when you get a positive result. And now I am asking, I'm getting a positive result, but what are the chances of actually being a negative, not the positive? So this means all the chances in which I got a true positive, right?
Yes.
So this will be equals to 1 minus, because 1 are the total chances. And from this 1, I want to subtract all those chances of being a true positive, which means 1 minus positive predicted value. Yeah.
And why don't we do like 1 minus sensitivity? We are talking like
You can do it
all
like
the
that, you will
chances
get the
that
same
it is
result.
possible.
You will get the same result. You can do it like that, okay? You will try. Let me try for you, okay? Don't worry. See. This is the graph, the true positive, okay? And this corresponds to the false positive. This is the false negative. This is the true negative, right? Yeah. And my positive predicted value will be equals to true positive divided by true positive and false positive, right? If I do 1 minus positive predicted value, this means 1 minus true positive divided by uh, sorry, only this term will be divided by the true positive and the false positive, right? Is that okay?
Yes.
So what I got now is equals to the true positive plus false positive I can take upward, and yeah, the true positive plus the false positive, and from upward I can take it back, and this is a true positive plus this false positive minus the true positive, right? True positives and true positives are gone, and what you get is the false positive upon my true positive and the false positive. The same thing. Is it okay now? The false positive is the same thing, right? You wanted to know that. And what are the chances in which I'm actually negative when my tests are positive? So you will consider all the scenarios of being a positive, then you will minus them. Is it okay now?
I asked why are we not saying like 1 minus sensitivity if we are saying of all the chances we test positive, like true positive. Why are we taking it
No, it
TPV
is
and not
not the same
sensitivity?
thing. Positive predictive value is not the same thing as a sensitivity. They both are different thing. You cannot confuse between the two terms.
No, I'm not
Sensitivity,
confusing the two. You said
sensitivity, yeah.
Mhm.
Ask.
You said we will exclude all of the cause, all of the chances that we turn positive. So we will do like 1 minus
After
TPV.
my test is positive, I'm returning all the chances where I am a true positive.
Yes.
Yeah, this is a positive predicted value. Which are these chances, right? The true positive upon my true positive plus false positive. These are the chances where I'm actually a positive with the disease with my test positive. Is it or not? These were not the
Okay.
sensitivity. I'm
Yes,
taking the
that makes sense.
I'm taking the actual scene here, right? This is the actual scenario. The true positive rate is actually the scenario for the population, and the sensitivity and the specificity is for the test, not for the population. If you remember,
Yes, yes. Get it.
okay, that's why I'm not using a sensitivity here. So if the step one asks you that a chance of being actually negative despite a positive result, this would be equals to the 1 minus positive predicted value. You won't use a sensitivity because sensitivity is not for the population. You know, both of these things are different. Okay, should I move forward now?
Yes.
Yes, please.
So we have finished with the confidence interval. Yeah. And now we're going to move forward for the meta-analysis. Meta-analysis happens when when you just merge the multiple studies. Okay. There are multiple studies going on around the world on the same thing. Okay. On the same enzyme or a same research is happening, right? In the multiple areas of the country or the world. And when you merge all of the studies to one, to increase the sample size, because some studies use sample size of 80, some use 1000, some use 2000, and when you merge all the studies into one, because they're actually studying only one thing, so you can increasing the sense the sample size. Is it okay? Yeah,
Yes.
you're increasing the
Yes.
sample size, right? So this is a
Yeah.
meta-analysis. Okay, so multiple studies are pooled into one study to increase the sample size. And after the merging every study, you will study the sample size of the new study. Okay, this is the meta-analysis. It will improve the power. Like I told you, if you increase sample size, you can increase the power. Okay, you will also increase the strength of the evidence and the generalizability of the study findings. But it will limit the quality of the individual study and the bias in the study selection, because different studies uses a different method of selection. Different studies are being performed under under the different circumstances, right? So when you pool this study into one, the different conditions are created now. Okay, so this meta-analysis is limited by the quality of the individual study and the bias in the study selection. Very important to know. Okay, this is the only limitation of the study, because when you merge different studies, a different study have a different method of getting the same results. Different bias could be there, different circumstances could be there. Okay, so you have to neglect all these things, and when you're neglecting all these things, you can get an error in the meta-analysis. Okay, any doubt for the meta-analysis?
No.
No.
Okay, now then you need to understand upon the two type of variables. Okay, one is the qualitative variable and second is the quantitative variable. The number which can be quantified, the variable which can be quantified, like the kg weight, like the height, okay, like the sample size, like the enzyme level. Okay, the number which you can easily be quantify is known as the quantitative value, like 1, 2, 3, 4. Okay, the number which you cannot be quantify, for example, yes, no, high, low, or the percentage. Okay, these are known as the categorical values. Okay, okay, so categorical values and the quantitative values variables, the two type of variables exist. Okay, this categorical is also known as a qualitative variable. Okay, both are the same things. Categorical also as a qualitative variable, and the quantitative variables are these ones. So any number or any variable which you cannot quantify is known as a categorical values. The high, medium, low, yes, no, positive, negative. Even the percentage is also a categorical or the qualitative variable. Okay. For example, if I say 40% of the people take the drug A, then I'm not quantifying how many of the people taking drug A. It could be 1,000 or 40%. It could be a 2,000 or 40%. Right. So when I quantify like 40 individuals are taking drug A, it is a quantitative variable. When I say 40% of the individuals are taking drug A, it is a qualitative or the categorical value. Okay. Understand this? The difference between the quantitative and the qualitative variables or the categorical
Yes.
values.
Yes.
Now we need to
Yes.
move some common statistical tests. Okay. So see. So there are two types of variables again, apart from these. One is a dependent variable and second is the independent variable. Okay. For the independent variable, these are the exposures which are independent of the study or the independent of anything. Right. This is the exposure. Exposure is always a independent variable. Then comes a dependent variable, which is the outcome that is dependent upon the exposure. Okay, so outcome or the disease that you know, this is the dependent variable, which is dependent upon the exposure, and exposure is the independent variable. Whenever you perform a study, okay, in which the exposure is the dependent variable, okay, and the outcome is a whenever you perform a study in which the independent variable is a qualitative variable. Let me go forward for this one. Yeah. See, whenever I perform a study in which the dependent variable is a qualitative or the categorical value, and the dependent variable again is have a this value, the qualitative value. Okay, then I can use either the chi-square or the Fisher or the logistic regression. I will come into that later. Okay, just note a table for now. Okay, if my study has an exposure or the independent variable as a qualitative variable, and I want to assess the outcome on the basis of yes, no again, then it is a chi-square or the Fisher I can use, or I can also use the logistic regression. Okay, if in my study the exposure is a qualitative variable, whether I've taken the drug A or not, yes, it is a qualitative, and I want to assess the outcome on the basis of a quantitative variable. Let's say I'm taking a vitamin therapy, and this vitamin is known to increase the level of iron in my body, right? So if I'm taking the vitamin or not, it is a qualitative variable. Okay, and how much how much the iron level is increasing in my body for, let's say, the individuals who are using the vitamin, they have the iron level of 90, mean 90, and the individuals who are not using the vitamin supplements, they have the iron level of like 60 or 50, mean. Okay, so as you can see, the outcome is a quantitative variable and the exposure was the qualitative variable, the use yes or no. So now the test I can use is the t-test, okay, or the ANOVA test or the linear regression. The t-test, yeah, ANOVA test or the linear regression. Okay. Now, if I have a quantitative variable which can easily quantify, like I'm taking a certain drug in a certain amount, like 650 gram or 500 gram of a certain drug. Okay. And now I want to analyze the outcome on the basis of a qualitative, like say for a drug for the pneumonia, whether 650 gram of this drug is treating the pneumonia or not, whether the 500 gram of this drug is treating the pneumonia or not. If I want to analyze like that, so pneumonia is maybe a yes, no, and the amount of drug is a quantitative variable. Okay, now now the test that I must use is again the logistic regression. Okay, then comes a scenario where my exposure was a quantitative variable. Okay, and my outcome was also a quantitative variable. Now I must use the linear regression or the correlational analysis. Very important. Either the linear regression or the correlational analysis. Okay, then let's go back to the page. So whenever we want to check the difference between the mean of two groups, okay, and my exposure must be a qualitative variable. For example, the comparing the mean blood of the mean blood pressure of the man and the woman. So either you are a man or either you are a woman, okay, not in between. That means it is a yes no condition. That means it is a qualitative variable. So my exposure, man and woman, is a qualitative variable. Okay, and my outcome, the mean blood pressure, I can calculate mean blood pressure very easily, like 120 or 130 or 140. I can easily quantify it. That means my mean blood pressure is a quantitative variable. Whenever I have a two groups and I want to compare their mean, it is always gonna be a t-test. Okay, and whenever I have three groups instead of two groups, and I want to compare one value in all these three groups, then it is a ANOVA test, analysis of variance. Okay, whenever there are three or more groups, it is always the analysis of variance. Whenever there are two groups, it is the t-test. Let's say I want to compare the mean BP in three ethnic groups. So multiple groups are there, more than two groups are there. That means it is for the ANOVA. Okay, and my exposure must be a categorical value. Okay, a yes no. Either you belong to this ethnic group, or you belong to this ethnic group, or you belong to this ethnic group. No in between. Yes. And for the BP, it is always a quantitative factor. You understand this? Understand it, or I should repeat it again?
I got it. You can move forward.
Okay. Then comes the chi-square. As we have discussed, for the chi-square, you need to have a qualitative independent value, and again the same qualitative as the dependent value. Okay, whenever you want to check the percentages or proportions, then you will always use a chi-square. For example, if you want to compare the percentage members of three ethnic groups, then three ethnic groups, if you want to compare whether these three ethnic groups have the hypertension or not, how many percentage of individuals in these groups have hypertension, and how many of them are not having any hypertension. So either you have the hypertension or you do not have the hypertension. Either you belong to this ethnic group or you do not belong to this ethnic group. So both the variables are the categorical values, or these qualitative variables, right? And in this scenario, you will use the chi-square test. Okay, very easy. Then comes a Fisher exact test. It checks the differences between the two percentages or the two categorical values. Okay, and whenever your sample size is kind of very much small, okay, whenever the sample size is small, it is same as a chi-square test. Okay, it is same as a chi-square test, but in the Fisher exact test, the sample size is very small, like 20 or 30. But in case of chi-square, it is 200 or 1000 or 5000, something like that. Okay, so whenever the sample size is small, you will use a Fisher exact. Whenever the sample size is very large, you will use the chi-square. Your independent variables in which you're going to divide the group. Okay, independent variables are those variables on the basis of which you're going to make the group. It is always a categorical in case of a chi-square. Okay, and the outcomes that you want to study, this must be the two categorical outcomes. Okay, then you will use a chi-square. And once you divide the group on the basis of a qualitative variables and you use them to get a quantitative outcome, then you will always use the t-test or the ANOVA test. Any doubts so far?
In Fisher exact, we compare the result between two groups, and in chi-square there are three. I mean, two or greater than two.
Yeah, it could be more than two. Yeah. In the Fisher sample size, the main thing is the sample size. If the sample size is small and two groups are there, you can use a Fisher exact. Okay. If the sample size is big and two groups are there, then you must use a chi-square. Okay. Or if the groups are more than two, like 3, 4, 5, then you will always use the chi-square again. Okay.
Okay.
Okay. Now, then comes the logistic regression and the linear regression. FA didn't mention it. I don't know about 2021 edition. But does it mention it? Logistic and linear regression. Does 2021 mentioned it?
Don't know.
Okay, don't worry, we'll go. Okay, so whenever you want to use a logistic or the linear regression, okay, you always want to have a multiple exposures. Like in the previous cases, we have divided the group on the basis of ethnicity, or we have divided the group on the basis of a sex, male or female, or the ethnicity, black, white, or something like that, right? But whenever we have divided the group on the basis of multiple exposures, like say one group is taking the vitamin A, one group is taking the vitamin B, and the other group is taking no vitamin. So multiple exposures are there, right? And whenever the multiple exposures are there in the independent variables, you will always use either the linear regression or the logistic regression. Okay. Now with the multiple variables, which are either could be a qualitative or the quantitative, doesn't matter. If the multiple variables are there and you want the outcome as a qualitative one, okay, you have given a certain, you have a population, some of the individuals in the population get a drug A, some get a drug B, and some get a drug C. And now you want to analyze whether this drug is helping in the hypertension or not, whether this drug, these drugs are useful for the hypertension or not. So after analyzing the data, what you have found that certain individuals who were using the drug A, they have the BP low, so they're out of the hypertension. Certain individuals who are using the drug B, they also get the low BP and they will get the hypertension, or they are out of the hypertension. For the drug, no, for the placebo or no drug, no hypertension cases are found, something like that. So you are using the quantitative or the qualitative multiple exposures for one a qualitative variable outcome. Okay, and whenever a scenario is something like that, you will always use the logistic regression. Okay, understand it?
Yes.
Okay, and whenever the multiple exposures are there and the outcome is a quantitative outcome for, like say, certain vitamins which are increasing the iron level in your body, the vitamin something X or a vitamin Y and no vitamin, and you want to check the iron levels, which are affected by these vitamins. Okay, so basically you created three means. Okay, those individuals who are using the vitamin X, they get a mean of this X. Okay, certain individuals who are using the vitamin Y, they will get a mean of Y in the iron. Okay, and the certain individuals who were not using any kind of vitamin, they get a mean of Z in the iron levels. So comparing the mean, actually a quantitative variable on the basis of either the qualitative or the quantitative ones. So whenever a scenario is something like that, you will always use the linear regression. Okay, you will always use the linear regression whenever a multiple exposures are there. It doesn't matter if they are qualitative or quantitative, but the outcome is a quantitative one. You will always use the linear regression. Is it clear now?
Yes, is regression analysis and linear regression are the same?
Yeah.
Yeah, just another name.
Yeah, exactly. Regression analysis of two types, linear regression and the logistic regression. Okay, it is of two types.
Okay.
The same thing. Okay, then the final one is the correlational analysis. And like you see here, the correlation will be done when both the exposure and the outcomes are the quantitative ones. And whenever you need to find a correlation between the exposure and the outcome. And please note that this correlation doesn't mean that the exposure is directly affecting the outcome. Okay, it just means the disease process which are causing the outcome to rise, they're also causing the exposure to be there. Understand what I'm trying to say? This exposure is not directly affecting the outcome status. Okay, it's just the disease process which is affecting the outcome. It is also affecting the exposure. Okay. Are we good?
please repeat it or give some example?
Okay, let me give you an example. Let's say the coffee and the blood pressure. Okay, you want to know the relationship between the coffee and the BP. Okay, and you found that all these individuals which are high BP, they're also having a very high coffee intake. Okay, but it doesn't mean that the coffee is directly causing the high BP. Okay, but a disease process is there. Okay, and in which you are getting the high BP, and all these individuals which have this disease process, they're also taking too much coffee. It is something like that. Okay, all these individuals who are diseased, they are having this high BP, and all these individuals who are diseased, they're also using the coffee. So it is like this, it will make it look like the coffee is the cause of BP, but no, it was a disease process who are this causing the high BP in the individuals who are using the coffee. Okay, so you can say there's a correlation exists between the coffee use and the high BP, but it's not that the coffee is causing the high BP directly. Okay, or you can say the level of two enzymes in a disease. Let's say the level of two enzymes like CKMB and the troponin in case of a myocardial infarction. You get a rise of troponin and a rise of CKMB in case of myocardial infarction, right? But it doesn't mean that a rise of troponin is causing the rise of the CKMB also, CKMM or CKMB also, right? Yeah.
Yes.
Should I repeat again? The myocardial infarction case. In case of a MI, you get two enzymes level high. One is a troponin, one is a CKMB or a CKMM. Okay. Now, what's gonna happen whenever the MI happen? These two markers will rise. Okay, so you can easily say whenever the troponin is raised, the CKMB is also raised. But it doesn't mean that the rise of troponin is causing the rise of CKMB. But the disease process, which is the MI, is actually causing the both of the enzymes to be raised, right? But not each other is true. Okay, this is the correlation. Yeah.
In this example, both CKMB and troponin both are quantitative. So which
Yeah.
one of these is dependent variable and which one is independent variable?
Anyone could be dependent, anyone could be independent.
Because dependent we mean its outcome and independent we mean risk
It is
factors.
not
So
entirely true for the correlation actually. In the correlation, you just want an correlation between two quantities. As you can see in the graph, let me go back. You will study that later again. See, you just need a correlation, as you can see in it. Whenever the one quantity is rising, the other quantity is also rising. It's just this. Okay. If you want to know the relationship between this troponin and the CKMB, then you can either take the CKMB at this outcome site, or you can take the CKMB at the this exposure site. Doesn't matter. Okay. These values are actually not true for the correlation actually. The graph. Just forward here this. The exposure and the outcome is not true for this correlation. It's just both the quantities are the quantitative. Okay, you can neglect this thing, the outcome and the exposure. Okay, both the quantities are just the quantitative, and you want to know the relationship between these quantitative values, the correlation between the quantitative values. So whenever the step one will ask you what is the correlation, how you can find the correlation between the two quantitative values, it is by the correlation analysis. They will mention this word correlation or relation. Just if they mention the word relation, you can immediately know that it must be the case of correlation analysis. Okay, then let me go back again and let me try to explain you this. Whenever you have a value which is closer to 1, okay, you will always have all these value on this linear line. Okay, and whenever the value of R is apart from 1, you will have a scattering of the data, as you can see. Okay, and the values always exist between 0 to 1. From -1 to +1. Okay, values always exist between -1 to +1, Okay. A minus means opposite, which means when one enzyme rise, the other enzyme will fall. Okay, as you can see in this example, and the value which is more closer to 1, it has a very strong association. Okay, the value which is closer to 1, it has a very stronger association. Okay, and negative means when one marker rises, the other marker will fall. Okay, and the positive means when one marker rises, the other marker will also rises. But it doesn't mean that the rise of this marker is causing the rise of this marker also. It is a disease process which is common for both of them. Okay, so a positive R value means a positive correlation. As one variable increases, the other variable will also increases. In a negative R value, when it is means a negative correlation. When one variable increases, the other variable will decreases. And the closer the absolute value of R to 1, the stronger is the linear correlation between the two variables. Okay. The regression analysis is same as that of the linear and the logistic ones. You will have multiple exposures and one outcome. Okay. Either it could be a qualitative, it could be a quantitative, depends. So for example, if the R value is 0.6, that means there is 60% variation in y-axis that can be explained by the x-axis. 60% variable in the y-axis that can be explained by the x-axis. Matlab 60% of times or the 60% of rise of troponin I can explain on the basis of CKMB levels. Okay, because CKMB is rising, I can say that the cellular destruction is there, and because the cellular the cell membrane rupture is there, the troponin is also leaking. So I can say that because of the CKMB rising, I can explain the rise of troponin also the same way. Okay, so the correlation is just a way of explaining the two variables, why they are put together always, right?
Yes.
I can say that the CKMB levels are rising because of a membrane rupture, and because of this membrane rupture also, the troponin levels are rising. So I can correlate between these two values, but it doesn't mean that the CKMB levels are causing the rise of this the troponin values also, right? And the R value 0 means there is no correlation between the two quantitative variables. Okay, you will get a flat line like this in this line. Okay, so they will just ask you the R values. They will give you a certain graph and they will ask you what R values it could be there. Okay, and they can ask you whether it is a positive R value, whether it's a negative R value, and they will give you a certain scenario and they will ask you what test you will use to find a correlation or a relation between these two variables. So you need to look first thing, which is both must be the quantitative ones. And once you assured that the two variables which are given in the statement are the quantitative ones, and the question is asking the relation between these two variables, that this means that this must be the correlation analysis. So either they can ask you the name of the analysis or they can ask you the R values. Only two questions are possible from this paragraph. Okay, no other question could be made. And they can sometimes give you a statement that this the rise of this marker is causing the rise of this marker, or that the rise of these markers are independent of each other, or these are both associated with each other. Okay, so please look for the statement questions, look for the name of the this analysis question, and look for the R questions. Only 3 questions are possible. Okay, from this correlation coefficient. Any doubt in it? Please ask.
No.
Okay, so we have finished with the biostats and epidemiology.
Dr.
If I doubt,
Brando.
you can, yeah, please ask.
Hello. Sorry, I'm sorry to take you back. What I didn't understand what you said happens when the sample size increases to the confidence interval. You say it reduces.
Where?
When the sample size increases, what did you say happens to the confidence interval?
When the sample size increases.
Yeah.
Okay, see, you know that the confidence interval actually is equals to the mean plus minus of standard error multiplied by this 1.96 or 2.58. Okay, right?
Yes. Yes.
And what is the formula of standard error? This would be equals to the standard deviation divided by the under root of sample size.
Okay.
If I increase the sample size, then this term, let me circle it. If I increase the sample size, then this term will be decreased. If I increase the n value, the sample size, would this term will be decreased?
Yes.
Let us suppose the term initially was 2 and it is now decreased to 1. Okay, and the mean was, let us suppose, 4. So initially what values of I had 4 plus minus 2, but now what values I have? 4 plus minus 1.
Okay.
Right? So should my range is increase or decreased?
Decrease.
Huh?
Decrease.
Decreased, exactly. So whenever I increase the sample size, my confidence interval values, the range is decreasing. And similarly, when I decrease the sample size, the range of my confidence interval is increased, or the width of the confidence interval is increased. Can I say that?
Yes.
Okay, is it clear now?
Oh, okay. Yeah, thank you.
Thank you so much. Any other doubt on the biostats?
What about probability and the problems like that?
What probability problems?
Yesterday you said that we will do it separately.
Yeah, okay. Let me go back to them. Okay, I forgot to make a question on it. I'm sorry about that, and I would definitely make a question tomorrow. Okay, on this one, I forgot about that completely. Okay, I will make a question from it. Okay, and then I will explain it to later. Okay.
Okay.
I forgot the questions on this. Okay, so I'm sorry about that. Okay, any other doubt? For the confounding and lead and length time bias, I will discuss this to tomorrow also with a separate slide. Okay, a more detailed questions I will prepare for them so that you can have a better understanding of these topics. Okay. Yeah, as someone was asking, I think. Anyone asking a doubt?
Now it's clear.
Okay, so I think we should wind up here, and we are finished with the biostats. Okay, and tomorrow we will start with the cardiology. We will skip this the ethics part for now. Okay, we will do the ethics in the last. Okay.
Okay.
It is kind of a self-reading thing because I feel all the things that you need to know, it's kind of a self-reading only. Okay, so we will discuss the ethics at the very end with some questions. It would be better. And so tomorrow we will start the cardiology. Okay.
Okay.
Okay. Thank you.
Thank you.
Thank you.
Thank you.